has its representation within pediatrics. We have neurological conditions ranging from cerebral palsy, Erb's palsy, transverse myelitis, and a host lot of others. We have genetic conditions. We have genetic conditions like muscular dystrophy, Down syndrome, sickle cell disease, thalassemias, all of those. We have them as genetic conditions within pediatric practice. In the musculoskeletal and orthopedic aspects, we have conditions like fractures that could be caused by traumas. We have almost every specialty within pediatrics has a musculoskeletal representation because they present with musculoskeletal issues. So we have also rotational deformities that as a result of biomechanical issues with skeletal development. We have them represented in musculoskeletal and orthopedic group. We have cardiopulmonary conditions like cystic fibrosis. We have a lot of childhood asthma. We have pneumonia. We have heart conditions, tetralogy of Fallot, always associated with Down syndrome. We have sensory disorders like attention deficit hyperactivity disorders. We have autism. And all of these conditions, all of them have, in one way or the other, there are some of them that would require us to do radiological investigation to be able to determine which particular condition we're dealing with. So as pediatric physiotherapists, it's very important that we know how to read these films and interpret them by ourselves. Because what we get out of the radiologist is not always what we aid our diagnosis and our eventual treatment. As physical therapists, we need to be able to see alignments. We don't just, for example, there can be an X-ray that will come to you, and then it will just be like the radiologist reports is saying that it's there's a fracture shaft of femur. But as a physiotherapist, you want to see what the relationship between that fracture is with the two adjacent joints that are there, so that in your management you'll be able to know what you're aiming your management towards. Will it be restricted to, just building the muscles in that area? Will you have to treat mobility and flexibility in that joint if the fracture is so close to the joint? So as a physiotherapist, we need to understand and be able to interpret some of these. We need to be able to interpret some of these imaging techniques, because they help us to conclude our evaluation objectively. So it's very important as pediatric physiotherapists to be able to understand them. So most of the imaging techniques that are available to use in pediatric physiotherapy, in medicine generally, we have X-rays, which are conventional radiographs. We have CT scans. Conventional radiographs will only give you images of bones. You'll be able to understand bones and joints in them. You can see the outline of muscles, but you can't see anything that might be wrong with the soft tissue. You might see a swelling, you might see atrophy, but you can't see particularly whatever soft injury might be there. With the CT scan, it does basically most of what the X-ray will do, but it's like a gold standard where we have multiple injuries. It gives us a better picture of all the places that could be affected. Oh, sorry. So it gives us a better, the computer tomography, the CT scans will give you a better outcome when you want to view multiple injuries. It gives you a better outcome when you want to view degenerative conditions, and you also use it for brain and neuro conditions. But both these two modalities, they use ionizing radiation, and they have their own, a lot of side effects with them, radiation side effects. So came the MRI. The MRI can visualize soft tissue. It can see blood flow and fluid contents. It can see nerve activities, and it does not use ionizing radiation. So it's actually an image of choice. It's a modality of choice, especially when you have to, apart from its cost, it's a modality of choice for children. An ultrasound is actually the cheapest and the best for children. But most of the time, the benefits of using an X-ray outweighs the risks of it. And it's what will give you the image that you want, and you wouldn't need to go high up there. So in children, the safest to use is mostly the ultrasound and the MRI. The ultrasound can be used to visualize soft tissues and organs. And the bone scars are like the ultimate. They will see everything. They will be able to see whatever minuscule thing that is wrong with the bone. So viewing the radiographic images, as in for X-rays, there are 3 ways that they do X-rays. They can just bring out X-ray as a film. They can do digital X-rays, and they can do fluoroscopy. Fluoroscopy in the sense that they can introduce medium to be able to see clearly some of the features that could not be seen on an X-ray ordinarily. They use it in the barium milk test for the GI. They can do it for, what do they call this? For the kidney too, they use it when they want to do IVU or something like that. I've forgotten the full name of the IVU, but they do the fluoroscopic technique. They introduce the medium and take the X-ray, but all of them are just a snapshot. They will just go there and give the films. So what we see on the X-ray basically is an interaction between the body tissues and the magnetic ionizing radiation that has been introduced. And what we see on the X-ray is as a result of the radio density, as in how that tissue is able to absorb the X-ray, the rays, or reflect them. So it's the radio density of a tissue or object that determines what you see on the X-ray. The radio density is also dependent on the composition of that object or the thickness of it. So we are just restricting ourselves to tissue. The composition of the tissue and thickness of the tissue determines what the radio density is. Now, when you pick the radiograph, what you see is the radiographic density. The radio density relates to the tissue, but the radiographic density is what you see on the object, on the film. So what you see on the film can be ranging from white to gray. And these tissues are further categorized into 3. Those ones that are radiodense, those ones that are radiolucent, and those that are radio-opaque. But the greater the radio density of a tissue, then the lesser its radiographic density with an X-ray. That means if, for example, we have a bone that is thick and heavy in composition, the radiographic density will be less. So it's going to be bright on the X-ray, bright tending towards gray on an X-ray. So radiographic density is just telling us the darkness, the degree of darkness on an X-ray. Objects that are radio-opaque stands for only objects. It cannot relate to humans because they are implants, metallic implants, teeth implants, all of those, they are referred to as radio-opaque. On the X-ray, they will come out as very white. But when we have thick tissues or organs, we call them radiodense because they're going to reflect degrees of shade depending on the thickness and the composition of that tissue. So for the tissues that are thick and dense, you always call them radiodense tissue. So for the tissues that are thin, they are called radiolucent, like air, like water. On the X-ray, you just see darkness because you are not able to view them on the X-ray. So you just see them as dark. So it's just as is reflected on this X-ray. On this chest X-ray, we see bone. Because of the calcium content on it, it's nearly white because its composition is calcium and probably it's heavy. So it's reflecting as a white object. The air within the lungs is being seen as black. Fat tissues are seen as dark gray. Mostly they are between the muscle sheets. Then implants are supposed to be seen as extremely white. So organs that have air in them include the trachea, the lungs, the stomach, the digestive system. When you take an X-ray, you should be able to see darkness and then the highlights of the that when you see a bolt of darkness within an outline of an organ, then there is air in that place. So that's probably the context that they use in seeing all these pneumo conditions, pneumothorax and pneumoperitoneum and all that. So the fat, I said that you see it as a gray-black. So you see fat within the viscera and then between muscle sheets. Then all fluid-filled organs, they are just going to be gray. They are not going to be so visible on an X-ray. And then the bone will be tending towards white, and the degree of white and grayness depends on the composition of that bone. It is said that the teeth would have the brightest, it has a higher concentration of calcium, so it will have the brightest consistency. And then radio-opaque objects are always very white, but they are metal implants. And then contrast media, like the barium we talked about, is also going to be reflected as white. So just like the X-ray, the CT scans also use radiodensities. The radiodensity of the tissue depends on, the radiodensity of the tissue tells us what you see in the X-ray, in the scan, in the film of the scan. When the tissue is thick, it will appear white. And when the tissue is thin, it will appear dark. That means hyperdense tissues will give you whiteness on a CT scan, and hypodense tissues will give you darkness. For example, the lungs will also remain dark. So it's basically the same thing as the same view as an X-ray. And then subcutaneous fats will be dark, and then the bone will appear very bright, brighter than that of an X-ray, that of an X-ray. The CSF would appear dark because it's liquid and it's tending towards an X-ray. The gray matter in the brain is always denser than the white matter. So for the CT scan, the gray matter would appear bright and the white matter will be darker than the gray matter. They are just a shade of gray apart from each other. But the skull bone is going to be completely bright. The blood vessels can only be seen when a medium is introduced, like in the CT angiography. So here is an example of a CT where the patient has an extradural hematoma. So the skull outline is completely white. Then this hematoma collection is grayish. For the MRI, it will require, it does not use radiodensities of the substance. MRI is a signal intensity works with as the intensity that comes, how much of it is being absorbed by the tissue that you are trying to view. And then they do 3 views of the MRI. We have the T1 weighted view, the T2 weighted view, and the T1 weighted, the T2 weighted, and the flare. All of them are interpreted differently. The T1 weighted and the flare have similar properties in viewing them. Here, the T1 weighted will have its gray matter darker than the white matter, and that is all these reflections within the film that you see. The gray matter will always be darker, but with the T2 weighted, the white matter will be darker. Do you see the difference? The gray matter is darker here, but with the T2 weighted, the white matter is darker. But with the flare, the flare should also have the gray matter darker than the white matter, but it has the CSF appearing dark. So the flared MR is generally much darker than the both of them. So with T1 weighted, the fat signal is very bright, but the T2 weighted has gray because it has the signal intensity is intermediate for it. With T1 weighted, you will see CSF as dark, but with T2 weighted, CSF will be bright. Muscle tissues will be gray in both of them, and then the bone marrow will appear bright in the T1 weighted, and bright tending towards gray in the T2 weighted. So even the interpretation of them are different. Maybe they will take that session in the afternoon. Using ultrasound for musculoskeletal imaging has been in existence for a long time. And it's the safest, and it uses high frequency sound waves, and is their reflection on this tissue, off of these tissues, that give us an image to see. But what you see with an ultrasound is always gray towards dark. So it requires that person has a special training in sonography and to be able to understand. So the results of an ultrasound is dependent sometimes on the sonologist that is doing the ultrasound, the knowledge that he has. We might not be able to read it much, but we need, because as pediatric physiotherapists, if there's availability of musculoskeletal ultrasound, it is safest for a child. But then it does not show us the bone, because the sound waves is not absorbed by the bone. Then the ultrasound can also be used for interventional radiology these days, where they need to take biopsy samples, fine needle aspiration for samples, and so they use it for guided evaluation and intervention. But basically, it gives you a real-time image, just like the MRI. Even the CT will give you a short video. It's only the X-ray that will just give you a snapshot. But the ultrasound would not visualize bones for you properly. And then it can be subjective, because the influence of the person doing the sonography, his level of knowledge determines the result that he's going to bring out for you. So, okay, I didn't say anything about echogenicity, right? Yeah. So these signals that they give out, I've said that the ultrasound film will just show different shades of grays. So the gray that comes out depends on the echogenicity of that tissue. That is the ability of that tissue to be able to reflect the sound waves. So most of the time, muscles and bossas within the joints, they appear darker than okay. Muscles and tissue, they appear dark gray. The fluid, they do not reflect sound waves, so they will be black, just like air in X-ray. And then bones are tendons and ligaments, because they do not even, maybe they absorb it completely, if I remember correctly. Okay, they reflect a lot of the sound waves, so they appear bright. They don't absorb the bones, the tendons, ligaments, they don't absorb the sound waves, so they reflect them, so they will appear light. The muscles absorb some, so they appear dark gray, and the fluid will absorb them, so they're just completely dark. So basically, X-ray is not too safe for children, but most of the time, their benefits outweigh the risk. So, because X-rays can inhibit cell growth, and we know that children are still growing. If used in pregnancy, it can cause mutation. So it can cause a change in chromosomes, and then it can increase the chances of cancer in later life. So the best way to use ultrasound would be to use the you should keep the dose as low as possible. And then you should always have a justification for requiring the ultrasound in the first place. We don't say, because this child has a fracture and it's been 4 weeks since I'm treating him, let me just do another X-ray. Why do you want to do that X-ray if it's not like the child is not improving or you're seeing something new? For children, you expect that at least within 6 weeks they should recover. So why don't we just wait till that 6th week before we do it? So most of the time, we should be able to justify why we need to do an X-ray, and we should keep the radiation dose. The radiologist will keep the radiation dose as low as reasonably achievable. That means the moment he's able to achieve an acceptable image, he should stop the dose. And then as much as possible, when they are taking the X-ray, they should cover up the child with the protective gear, except for that place that they want to irradiate. Mostly, I've said that the MRI and ultrasound, they're the best possible they're the best possible imaging tools for children. So thank you for listening to this. If we have any questions with this before we go on to the next one. Do you have any questions or contributions, please? Hello? Any questions or contributions? Okay. Okay. Let me try to share my next slide. Okay, somebody is asking a question about T1 weighted and T2 weighted images. For the MRI, this is just basically an introduction. They actually take images so they take clear images on MRI. So it uses radio waves, right, to create images of the organs, and it's non-invasive. So depending on what organ the requesting physician wants to visualize, the radiologist will determine which kind of weighted image he needs to produce. So as I've said earlier, what place that you need to visualize will determine on which image, which intensity of MRI you're going to use. Maybe the T1 weighted or the T2 weighted, or basically all of them are non-invasive. So if you're trying, for example, to visualize maybe flow of CSF, you know that you're going to be using the T1 weighted because it's going to give you a clear, bright signal of the flow. If the patient, for example, has hydrocephalus and they want to see the flow of the CSF within the brain, then they will do a T1 weighted MRI because they expect to see brightness with the CSF. Then if you want to see, if it's a muscular problem, it's a soft tissue thing and it's within the muscles, you want to do a T2 weighted because the T2 weighted will give you a very clear image of what is happening in the muscles. If there's a cyst, if there's any growth, you know. So the choice of weighting depends on what is being requested for, basically. So are we clear with that? The afternoon session, my colleague is going to go a little more in depth. Is going to go more in depth on the higher technology of CT. And so here today on this second slide, we're going to be discussing how to read the X-ray, what we see and what it probably means, and what it means for a child. What we see means for a child. Just a minute. So to view an X-ray, on the view of an X-ray, basically there are a few things that you would see. There are a few things that we will see on an X-ray. And to view the X-ray, we would have to put it on the illuminated viewing box. And then on the X-ray, we expect to see the patient's information, his age, his sex, his case number. We expect to see, these are markers. We expect to see the markers, the identification markers, and we expect to see the anatomic markers. The anatomic markers are the right or left that is indicated by R or L on the X-ray. And then sometimes when the radiographer had, carried out a movement before he takes the X-ray, is also indicated on the X-ray. When you see INT, it's probably indicating that he has internally rotated the lower limb before he took the X-ray. When you see WBT or erect, it's showing you that there is actually, he took the X-ray in an erect or standing position, or with the patient bearing weight on his leg. For the chest X-rays, it can be taken in inspiration, expiration. On the film, most of this is supposed to be indicated that it was taken with inspiration or with expiration. So you will see some of these abbreviations on the X-ray. So when you are viewing the X-ray, you put it on the illumination box. Sorry. You put the X-ray on the illumination box, and that X-ray should be facing you, as in it should also be placed in an anatomic position, but it's facing the person that is trying to read it. But if the X-rays of the extremities of the hand and foot, then the hand and foot should be pointing upwards. And then the X-ray should have all of these markers that I've mentioned, the identification markers and the anatomic markers. Those are basically most of the things that you would see on the X-ray. And then for a child's X-ray, there are a few things that you have to, not even a child, for every X-ray, there are a few things that we have to take note of. We want to see the alignment. We want to see the density of the bone, and we want to see the cartilage spaces. You know that we cannot visualize cartilage on an X-ray. It should just be a space, just like you see on a vertebral X-ray. You just see it should just be a dark space, and then the joint surfaces will determine the joint surfaces you see is what is telling you the thickness of that space, and then the thickness of the cartilage that is there. So with the alignment, first you are seeing the size of the bone. If you see the bone is exceptionally large, then you are thinking towards maybe this patient has acromegaly, maybe he has gigantism, maybe it's a child, is an adult with Paget's disease. So you want to check the enlargement in the bone for the size. You want to check if there's an extra bone, like in the fingers when they have polydactyl. You want to check if there's any congenital anomaly on an X-ray. If the alignment, when you are looking at the alignment, you are checking for congenital anomalies, you are checking for extra bones, you are checking for bony enlargements, or even absence of bone, like in conditions like amelia. Then you want to, when you are looking for those alignments too, you're also checking to see if there's any developmental problem, like scoliosis is a developmental problem, like genovalgum, like pes planus. All of those are rotational deformities that could happen because of biomechanical processes of skeletal growth. So when you are checking the alignment of bone, you need to check all of this. You need to check the contour. A bone that is supposed to be curved, is it curved the way it's supposed to be on the X-ray? Is it straight enough? You need to check all of those, because then you'll be ruling out congenital deformity, you'll be ruling out traumas. So you need to see those irregularities or irregularities when you are checking for bone. Then you should check the outline, the cortical outline. Is it clearly defined? Does it have any outgrowth? All those things you're checking with alignment. Is there any spots there? Do they have thickened margins indicating degenerative changes? Is there any break in continuity indicating a fracture? So you need to check for all of those alignments. Then you need to check also if it's a fracture case or maybe a case of osteomyelitis they've been trying to, or maybe as a case of osteomyelitis that probably they are trying to elongate the bone because of limb shortening. You want to see the previous drill areas where the orifice was removed before. Is it still there? Is it filled out? All those things you need to see. You need to see subluxation. All those are in alignment of the bone. Then you also want to see how the bone is aligned with other bones that are supposed to be relating to it in activity. So all those are things that you check for in checking, in interpreting an X-ray. So here you have checked for the architecture of the bone. You have checked for its size. You have checked for the number of the bones. You have checked for alignment within the bones and other bones, and you have checked for contour. So when you come to checking for the bone density, the shade of gray depends on the density. The shade of gray tells us the density of the bone. If it's gray, that means it has normal density. But if it starts becoming lighter and lighter, then the density is reducing. You want to see the relationship between the grayness of the bone and the air that is around the bone. Is it becoming darker? There are a lot of other anomalies that could, cause that. If the cortical margins are not very clear, then it's showing a decrease in density too. And then this bone density is also, I think it will also be determined by the amount of stress that is placed on the bone, because when we go to Wolff's law is stating that skeletal growth is dependent on the stress that the bone goes through, something like that. So if a bone is experiencing a lot of stress and all that, it should be stronger than the one that is not, experiencing all that. So it's also dependent on how much stress is being put on the bone, determines the density of the bone. So increase in this density, you can see them in developmental disorders, increase in bone density, because when there is, for example, genu-valgum, the body will still try to compensate, and then you will see that there's malalignment because of there's a bow leg, there's malalignment, and then one side would always compensate because the weight will go that side, and the bone on that tension side that the weight is going would, is it not the compression side? Yes, the weight on that compression side that the body weight is going would have more density than the one on the other side that is convex. But when it is low, you see it in osteomalacia, osteoporosis, you see low density more in such conditions. So now we check the general density. For bone density, they check the density. Then the abnormality in texture will be noticed by the trabecules that traverse the bone. If those fine lines are reduced, if the appearance of the trabecula is reduced, as in the fine lines are reduced, then if the fine lines are reduced, then there is an anomaly. For example, if the trabeculations become thin and lacy, then most likely is related to conditions of the blood like thalassemias. Sorry, it's my most likely is the image did not come out well on the phone, sorry. So if, for example, the trabeculations, I'm still in bone density. the textural abnormality, if the texture of the bone, the trabeculations, lines that are supposed to be seen on the bone are delicate or thin or lacy, then it could be that the patient is a thalassemia case. But if they are coarse, if there's like obliterated between them, is coarse like that, then it could be as a result of osteoporosis, or in patients with chronic renal diseases. If it's smudged, that means you can't even, there's no difference. It's just the same. Then it could be osteomalacia and also osteoporosis. But when it becomes fluffy, especially in the skull, we're now thinking about Paget's disease in adults. They're most of the time, Paget's disease will have fluffy outlook on their skull. And patients with hyperparathyroidism, they will also have that kind of skull. That is about trabeculations. And then the local densities is just as I described with bow leg, when there will be sclerotic changes because of hyperactivity on one side. You're bearing weight more on one side than the other. That means there's a local increase in density in just one particular area. Mostly they see this in osteoarthritis. So the cartilage spaces, normally we can't visualize cartilage on an X-ray. We're supposed to just see a space. And the space, we can't see anything within, because it contains, probably, it has a lot of water, and water is always dark on an X-ray. So you can't see much of anything with the cartilaginous spaces. But we assume measure all of these spaces by the width of the joint space. A decrease in the width of the joint space is suggesting that there's a degenerative problem. And then when there is when I've said that there will be, when there's reduction in joint space, the cartilage space is always that space that is between two bones most of the time. So this the thinning of any of the bone could also, or the thickening of any of the bone could put pressure on this cartilage and reduce this the joint space. Then the epiphyseal plate is also just a thin cartilage line between, not between two bones now, within a bone, at the end of bones. So these epiphyseal plates can also have injuries in children. So assessing X-rays in children is complicated by, I'll get there. It's complicated by their epiphyseal plates and their ossification sites, and I'll get there a little later. So basically, for cartilage spaces, we know that we're going to be assessing the joint space width. We're going to be assessing the width of the epithelial plates. Yes, thank you. And then we're going to be checking the joint capsules, and then the condition of the periosteum. But most of these things, the abnormality in them is seen in abnormality in most of these things will be seen in malignant cases. Abnormalities in the periosteum and will be seen in malignant cases. Okay, we'll still get to epiphyseal plates, because it's something that is very important to reading X-rays in children. Sorry, this one has gone away completely. But the slide was just telling us a little about skeletal pathologies that would require X-rays probably. We have, for congenital, we would have hip dislocations, rotational deformities, arthrogryposis multiplex congenital, craniosynostosis. And then for inflammatory conditions, we're thinking about gout, osteomyelitis, For neoplastic, we can talk about when it has become metastasized, malignant, and it metastasizes to skeletal tissues. Metabolic conditions like osteoporosis and Paget's disease, traumatic conditions, whatever kind of fracture, maybe multiple or, and then we have vascular conditions like avascular necrosis, leg cleft path diseases, and so forth. So as I was saying earlier, assessing the X-ray of a child is complicated by a few things within the child's body structure. It's complicated by the secondary ossification centers, by the epiphyseal growth plates, and then by the nutrient foramina. The secondary ossification centers and the epiphyseal growth plates, they're basically almost the same thing. But the nutrient foramina, they are within the metaphysis of the bone, but they are the hole through which blood vessels pass and nutrient is carried into the bone. But most of the time, in children, they are quite large and they can be mistaken for fractures. So ossification centers, we have primary and secondary, but the primary ossification centers are those ones that they are normally present in utero. So we're not talking about them now. We're talking about the secondary ossification centers. These secondary ossification centers are mostly always close to the epiphyses of bones. And they do not close up until late adolescence. It's the same with the what do they call this physial plates? Epiphyseal plates, the growth plates, and the ossification centers, they do not close until late adolescence. And they can even, the words can be used interchangeably because basically they do almost the same thing. They lengthen the bone or increasing the width. They do basically almost the same thing. And then it's only ossified bone that can be seen on an X-ray. You can't see, when a child is born, it still has more cartilage than bone. So if for any reason you have to take an X-ray, there is only the points that are ossified that you see, and the ossification will start from the shaft of the bone. So most of the time you have to, when you see those X-rays, you have to correlate with the skeletal age and the chronological age. Most of the time we do chronological age because skeletal age, you would have to start taking X-ray of hands and comparing them. So these are a few bones within the body that and their ossification times. The clavicle is the longest. It takes up to 25 years. No, the vertebra takes up to 30 years, I see. So it's, even as we grow, our bones still continue to strengthen. And then in as much as it has not finished strengthening, we're liable to get fractures easily. The epiphyseal growth plates, as I said, can be used interchangeably with ossification centers, but it's just a band of hyaline cartilage that lies between the metaphysis of bone. The metaphysis is that flared up area of the lower bone. If we take which bone now, like the femur, what's that V part? The V part that ends into the epiphysis is the metaphysis. So between the metaphysis and the epiphysis, there's a thin line of hyaline cartilage that's okay. Between the so the hyaline cartilage. Sorry, I can't use this. Anyway, this red band down here is the epithelial is the growth plate, and then down here is the epiphysis, and then this V part is the metaphysis above the bone. And the bone can have more than one ossification center and more than one epiphyseal plate, but they aid in the longitudinal growth of bone. This epiphysis it does not allow for any blood supply. here, the lower part does not allow for blood supply. So blood is being supplied into the metaphysis. The large foraminers are on the metaphysis, and then because this epiphysis is covered by the hyaline cartilage still, so there is no blood vessel entering through that. So any blood vessel that comes in from the metaphysis. And that's why for patients that are developing avascular necrosis, they would, when they want to do cord decompression, they actually just drill through the neck of the femur into the head if the child has passed the age of epithelial growth. When the growth plate has already sealed, they can drill through the neck and into the head just to revascularize the head of the femur. And then the person will have longer duration to heal. So the epiphyseal plate actually gets its nutrition from the shaft of the bone, basically. And then, not the epiphyseal plate, yes, epiphyseal plate and the epiphysis, they get their nutrition from the shaft of the bone. Look at this view of an X-ray. The epiphyseal plate appears like this. Because it's a cartilage, it appears dark. So any abnormality in this growth plate can affect growth. It can stunt growth, or it can delay it, or it can completely stop it. In radiography, there is a classification system for there's a classification system for injuries to the epiphyseal plate, and that classification system helps in determining the prognosis of it helps in determining the prognosis of any epiphyseal plate injury. As I've said earlier, the large nutrients are just, they're even in the diaphysis, not the metaphysis. The diaphysis is the shaft of the bone. So the foraminers that are allowed for blood flow, they are within the shaft of the bone. So they are the large nutrient foramen. If you take an X-ray of a child, you must correlate with physical findings, because it could be that it's not. If there's no swelling, there's nothing. It could be that there's no fracture. That it's probably just the foraminers that are appearing like a fracture. And then before we talk about the epiphyseal plates, we also would just briefly talk about the other type of fractures that can be seen in childhood. The green stick fracture, that one is the incomplete one. That one side will be broken, but it will not break into the cortex of the other one. And like in this image here, there's a fracture of the shaft, but it does not extend out to the cortex. The other side remains intact. So for bones, we have the tension side and the compression side for long bones. So the tension side is always the shorter one, the convex one, and then the concave side is the compression side. So green stick fractures are always complicated by angular deformities. So if angular deformities is developing, they would have to go back in there and do an osteotomy, break the leg and complete the fracture and realign them. So doing a repeat X-ray for a child with green stick would be if, for example, you start to see angular deformity, then you say, what is causing this angular deformity? And you want to do another X-ray against you. If not, most of the time they heal by themselves, except if it's this curved bone, then it can cause a problem. So the torus kind of fracture is like an impact fracture, like it's an impaction. So the bone is broken and impacted into each other, but it's not affecting most of the time it's due to fall when you try to break your fall. So it can compress the epiphyseal bone. And here the plastic bone, it's dependent on the elasticity of the bone. Most of the time, plastic bone will happen in places that have two bones together, like the leg and then the forearm. There could be fibular fracture. There could be fibular bone and when it fractures, it will cause compression. There could be, when there is a fracture on one of them, the other one will bend towards the area of the fracture, and then some of the time, it would even develop a green stick fracture, and they would have to go and break it and set it up again. The other fracture that can happen in children is epiphyseal fracture. Epiphyseal fracture cannot always be seen on an X-ray, depending on which type it is. If it's associated with bone, then you can at least see that. But the cartilage is not so easily viewed on an X-ray. But up to 20% of pediatric fractures are epiphyseal. And then there's a classification system that radiologists use to determine which we give a prognostic factor of which if the child will continue growing, or if growth will be impacted, or if the child will require a surgery, or if it can just be corrected by itself. And later there were additions to this, but they were not so widely accepted. So just stick with this later, Harry. So here's the type 1. The type 1 is just a fracture directly across the epiphyseal plates or just above it. Most of the time, the fracture is just above the epiphyseal plates or within it. So it still has a good prognosis of healing, and it still has a good prognosis of growth, because most of the time it's something that a child is born with. The type 2 will have a line through the epiphyseal plates, and it will exit upward. You see, so there's a chip. There's a line that goes through the epiphyseal plates or above it, and then it will cut up part of the metaphysis. So there's a triangular chip with the second one. That's what this X-ray is portraying. They said the prognosis is still good for normal growth. They will just reduce this fracture, and the prognosis is still good for normal growth. The type 3 is a fracture through the joint surface into the epiphyseal plates. So the chip is the epiphysis that is broken up. Something like this is through the joint surface, and it goes out there. So most of the time they will do in open reduction internal fixation, and it may not affect bone growth, depending on the. Well, they say here that it will cause a partial. It might cause a partial. It might cause a partial affectation with growth, partial arrest of growth. So the type 4 goes through the joint surface, through the epiphyseal plates, and through the metaphysis, and cuts that off. This one also requires surgery. Look at an example of a film. It also requires surgical fixation. But still, they said it still has a partial prognosis for growth that is likely not to affect growth. But the 5th type is a crush one. This one can cause it's like an impaction injury. It has eaten up the whole head. It has compressed the epiphyseal plate completely, and it's difficult to diagnose, surprisingly, because you can't see the cartilage on X-ray, except if you start to see other signs, maybe until the bone is not growing, because before you even know that there was an impaction injury onto the epiphyseal plate, and it can lead to AVN. But this one definitely will cause delay in growth. So basically, what we need to know is that radiographs they're actually standard when you suspect a fracture in a child, irrespective of all of its bad repute or radiation or whatever. They are the standard. All we need to do is to be careful. And limit the radiation to as low as possible. That is not our case anyway. It's the case of the radiologist. but it's something that we need to know too. When it's a complicated, maybe a trauma case, a complicated, more than one fracture associated with probably soft tissue injury, then we want to do a CT scan. If the soft tissue injury is extensive with all of that, then we would have to do an MRI. So when we don't even know if the child has a fracture or not, once there's joint effusion, maybe there's swelling in the joints and all that, or the elbow, then we should start suspecting that probably this child has a fracture, and then we can request for an X-ray. It's still the best to request for. If this effusion is in the elbow, we're suspecting supracondylar fracture. But if it's a supracondylar fracture, they say in younger children. But if the children are older, then it's a fracture of the radial neck. So it's, if the joint effusion is in the elbow, it could be two things depending on the age of the child. If the child is still quite young, then the supracondylar fracture is more suspected. But if the child is a bit older, then it's the neck of the radius that might have the fracture. So going on to chest X-ray, I didn't do much because I don't know much, but I'll tell you the little that I know. When you pick up the chest X-ray, you also want to look at the markers, the identification markers. It will carry the name and all that, and then the case number and the file. Then the anatomic marker, it will also carry which side, left or right. But then you also have to view it holding it in the anatomic position. Most of the time, all these left and right markings that I'm saying is not always correct that is the left or right, because there could be a mistake when they are taking and they'll put the artifacts that identifies the identifier in the wrong direction. But once you keep the image in an anatomic position, then you're safe. So you want to see the structures within the mediastinum. You want to see the heart, all those things, the trachea, all of those things that are within the mediastinum. You want to see that, yes, those structures are apparent on the X-ray. You want to see the lung fields. You want to see the bones, the ribs, the clavicle. You want to see that they're there. As a matter of fact, if it's a posterior anterior view, you want to see up to 10 ribs behind and about 6 reflected in front to accept that chest X-ray. You want to see the surroundings, soft tissues, that is organ tissues, the heart and its shape and outline. You want to see all of those. You want to see the diaphragm. You want to see some organs under the diaphragm. But for neonates, for adults, you do a posterior anterior view to see all of that. For neonates, you can do an anterior posterior view because there's nothing that is blocking. There's no shadow. There's nothing that is blocking. You can see everything intact. So you can even measure the size of the heart in that view. But with adults, you would have to do a posterior anterior view. You can see lung collapse in cases like pneumonia. I think the lung collapse will just appear, well, depending on where the collapse is, most of the time is at the inferior angle there. So it just appear, is it dark now or white? No, it appears whitish. There's no air. So there's a collapse. Then the pneumothorax will show a dark space because there's too much air. It could be pneumothorax, it could be within the peritoneum that there's a sac of air. So wherever it is that is fine air, it would be dark. Look at the first X-ray showing a pneumothorax. There's air within the thorax cavity, as in it's not inside of the lung, but it's within the cavity. That's why it's that obliterated part of the, you can't see some of the ribs so clearly. They are not as wet as they should be. So there's air within the thorax. The second radiograph is showing a collapse. You see, the collapse has even somehow obliterated part of the outline of the heart, and then it has made the lung appear smaller. So that whitish ness in the inferior angle is part of the signs of a collapse. So with children also, we have this condition that is like avascular necrosis, the leg calf fasciitis. Just like avascular necrosis, it's as a result of disruption of blood flow to the head of the femur. But unlike avascular necrosis, eventually there's revitalization and the head can go back into the round shape. But it occurs mostly in children between the ages of 4 and 6. And for those that will respond to treatment, they can get treatment for up to 18 to 24 months and recover. So the therapy treatment will now come on in the form of flexibility exercises and strengthening exercises. But as in the moment the place becomes revitalized again, then just like in this X-ray, see the recovery stages. The first stage, the head of the femur is already gone, and then probably following treatments, the head is forming back, but then there's fragmentation, and then eventually it comes back. This is an image showing a lytic lesion within the bone of a child with chronic osteomyelitis. You see, it's still contained within one place. It has not spread all over all the bone. The cortical margins are still intact, but there's this lytic lesions within the bone that is signifying that there's an abscess there. This is an image of a child with juvenile rheumatoid arthritis. It could be that it's not a child's X-ray. Well, I was just trying to depict a child's what rheumatoid arthritis would look like. There's subluxation in the big thumb, there's subluxation in the thumb. There's swan neck deformity. Okay, they call it bottonier deformity. And the little finger. I don't know. Can anybody see any other thing on this X-ray? Yeah? This is my last slide. Can anybody see another thing on this X-ray? The little bones of the wrist. There is a problem with the scaphoid. Maybe it has broken or I don't know, it's impacted. There's a problem with the scaphoid. So for patients with rheumatoid arthritis, the X-ray will show all of these deformities that they have. But once they get on their medication, some of the degenerative changes reduce. So thank you so much for listening. The next session is going to be CT and interpretation of the CT. But Dr. Boteru is going to take that part. So do we have any questions, please? Do we have any questions? So let's still think about the questions and let me try to get Dr. Boderu to join. Just a minute. Hello? Yeah, I just saw a question. Growth plate fractures. You want to know the difference between growth plate fractures and ordinary fractures in children? Are we all muted? Hello? You can just write it in the chat if I'm correct.
Yeah, because we only did.
Hello? Okay. Growth plate fractures would only happen at the end of wounds. And then even with the X-ray, I'm telling you that you might not see anything with the X-ray. But if it's other fractures that will happen with the bone directly, maybe on the shaft or the metaphysics or anywhere, as long as it's a bony fracture, you see it on the X-ray. But it's the epiphyseal plate fracture that you're not likely to see clearly, except if it has extended into the bone. If you want to know if it's now you want to know probably if it's a epiphyseal plate fracture or just you want to know if it's an epiphyseal plate fracture or a bony fracture. It will be probably in the continuity where it stops. If there's a supracondylar fracture that just hits the place where the epiphyseal plate is and it stops, then there's likelihood that it has affected the epiphyseal plate. And then you want to consider the age of the child. So any child that has not hit adolescence and has a fracture, a supracondylar fracture like that, then you should fear that probably there's an epiphyseal plate fracture. Then you have to request for a higher type of modality to be able to view it properly. I don't know exactly. Okay, so thank you very much. The moderator said that we can go on break and come back. I don't know what time. Let's wait for him so that he will tell us, because
okay, please, I want to ask a question, please.
Okay, go ahead.
Okay. When there in that slide you showed, that is the number 5 for epiphyseal fractures or so. I think the 5th one, that it's hard to detect that. The one that is crushed, that is hard
the crushed type, yes.
Yes. Now, would there be swollen? Will it kind of, normally when there is a fracture, we'll just see that immediately the place will get swollen, it will be so painful and something like that. Now, since the X-ray will not be able to detect it, we on our own will be able to detect it. Maybe there will be swelling, the place will be painful.
For this crush compression, you will see on the X-ray now, but the thing is that you might not even know that the child had any injury. As so in, maybe as a parent now. Okay.
There's not going to be any pain or swelling?
No, there probably will be pain or swelling. But talking in the aspect of from home before they get to you, they might not know that the child had any fracture until they see that that's in the context to which I was talking, that they might not know that the fracture affected the epiphyseal plate or anything until the bone, there is a stunted growth. But with the X-ray, they'll definitely see the crushed fracture, but they might not know that it had affected the epiphyseal plate until there's that stunting.
Okay. Thank you.
But most of the time, it's the radiologist that does this staging for us. In their reports, they will now tell us that it's stage something of Slater's stage something, and then to manage, you will now look for these stages and see what is affected.
Okay. Thank you.
You're welcome. Anyway, they said we are going on break and they will get back to us on. So they will come. They will tell us now when we are supposed to come back.
Okay, thank you, Ma, for the presentation.
You're welcome.
So, in the absence of any question or comment, we can go for a 1 hour break. So we will be back by 10 minutes past 1.
Okay, 10 minutes past 1. Okay, thank you, everyone.
Thank you for your presentation.
Oh.
Okay, so I'm showing you. Anyway, can you see it? Hello, good afternoon. Hello.
Good afternoon, sir.
Okay, sorry for the delay. We spent more than 30 minutes trying to uh, go on the network. Uh, I'm the second presenter. My name is Dr. Umar Muhammad Badaru. I'm going to take you on the second, third, and fourth module. The second module was on introduction to computed tomography. Actually, my first thought on this is to take some conditions, pediatric conditions, and discuss the detail, what do you call it, the detail I'm muted. Hello? Energy? Okay. Therefore, I have three modules to take. Introduction to computer tomography. Then after the introduction, we are going to look at the normal study of the city. What do we mean by normal study? When a city is normal, Okay, by way of introduction, are we together? We are still having little network problem, but by God's grace, we are going to do justice to this topic. We asked ourselves, what is computed tomography? Are you with me? And we said, computed tomography actually is an advancement over the normal X-ray that we know. But in this case, what happened is that images are produced of the slices through our body. Therefore, you can have up to 250 slices of tissues produced by the computed tomography. But actually, the basic principle is that of X-ray, meaning that it's an ionizing radiation. And we said, how does it work? It involves rotation of actually the source production and the source detecting Therefore, the source and the detecting, what do you call it, components of the CT are rotating in opposite direction, producing a circular motion. That is how images are formed. The computer then analyzes the number and density of the transmitted X-rays. The computer calculates Okay. Um, the network is
Okay. Sorry for the delay. Now everything is set up. We can start now. Sorry for the delay.
Okay. Good afternoon, everyone. Hello. Good afternoon.
Good afternoon, sir.
Okay. Actually, sorry for the delay. All the network went off, but we are back. We thank God for everything. Therefore, as we said, let me quickly recap. We said we are introducing computer tomography, and we said that computer tomography is an extension of what we know, the normal X-ray, only that it produces what do you call it, slices through our body, meaning that it can produce a lot of slices of our body tissues, and we said it works by the rotation of the source of the X-ray beam and the detector of the X-ray beam. They rotate in opposite directions such that they produce motion. In that way, they produce a lot of slides of our body, and they will say the computer analyzes the input and the density of all the tissues that have been transmitted, calculate coordinates, and produce elements that we call pixels, and we got the final picture. And we said nowadays, up to 250 slides can be produced by a single X-ray machine and CT machine, and the resultant images differentiate between soft tissues, unlike X-rays. In essence, what they are saying is that X-rays do not differentiate between fat, between blood, and between what do you call it, white matter, blood, what do you call it, gray matter, and all these ones. But CT can do that. Then they said it allowed direct visualization of intracranial content and abnormalities associated with the neurological condition, meaning that it is easy nowadays to say, following the slides, that this is ischemic stroke, this is hemorrhagic stroke, this is an infarct, this is an intracranial mass occupied lesion, like let's say a tumor. That is what it's saying. That the next is the advantages of the CT. Why do we opt for going for CT? They say it's inexpensive and widely available, meaning that there is hardly places where one cannot find CT. It's inexpensive compared to MRI, and it allows relatively quick assessment of intracranial content. Therefore, it is easy. If somebody have acute injury, head injury, has a, what do you call it, a sudden fall or sudden, yes, and then you feel that the head may likely be affected. Is you do quick assessment, and then you should be able to see something. They say images are very sensitive to the presence of acute hemorrhage or calcification. If there is calcification, you see whitish appearance. If there is hemorrhage, it's also whitish, but actually no uniform appearance. Okay. Then we have disadvantages of the CT. Patients are exposed to ionizing radiation. Yes, that is one of the disadvantages of X-ray. X-ray is an ionizing radiation. X-ray, for those in pediatrics, we know that it causes mutation and causes disease of body system. Therefore, also there is this iodine that is used as contrast. Therefore, iodine-based medium is used as contrast to enhance the image properties. Therefore, they said is one of the disadvantages. They said imaging artifacts can interfere with accurate interpretation. Yes, actually, it's subjected to having artifacts. If you have like movement, can be artifact. At times, the dose of the radiation, if it is too much, it will interfere with the results. Also, if there is a metallic substance in the tissue, it will appear as an artifact. Then, in particular, images of the brainstem and posterior fossas are degraded by strict artifact, the same artifact. Therefore, some of the images of what do you call it, the inner tissues of the body can actually appear with some artifacts that makes them less clear. We are going to see a section on the artifacts. Okay, here in the next slide, we see parts of the body best studied by the CT. They said head is an excellent screening modality for cranial trauma. The head CT is an excellent screening modality for cranial trauma, suspected intracranial bleeding, and stroke. Therefore, whenever somebody is having trauma in the head, we are suspecting intracranial bleeding, we are suspecting stroke. Therefore, the best modality to be used is the head CT. Then we can say the CT can also be used to evaluate paranasal sinuses, the sinuses in our forehead. It can be used to visualize the neck, facial bone, abdomen, and pelvis. And then they say for the knees, it is used to evaluate the tibial plateau only, but it is not good for cartilage and ligamentous injury. Therefore, when there is cartilage and ligamentous injury, it's better one uses MRI. Therefore, it is purposely actually is best when you are using CT. It visualizes the bones of the body, most especially the hardest bone of the body. It is easier for one to visualize it using the CT compared to MRI. Then we now have the disadvantages of the CT. Oh, okay, we have said it. Then we now move to the CT windows. Please, in every CT, there are two windows. The first window is what you call the soft tissue window. We are going to see the windows later. We have soft tissue windows and we have the bone window. In the bone window, what happens is it visualizes more of the bone. If you are suspecting like, let's say, cranial fracture, like skull fracture, then the bone window will now make all other tissues, like the brain tissues, homogeneous. They appear gray, all of them. Then only, only the bone will appear white. You'll be able to see the fracture. While in the soft tissue window, the interest in the soft tissue window is not on the bone. Therefore, the interest is on the soft tissue. Therefore, the soft tissue will appear more clearly than the bones. Therefore, it will be adjusted in such a way that it will emphasize the soft tissue in detail. That is what they mean by the two windows. You can have, usually the radiologists, what they do is, they have both the soft tissue and the bone windows. Even if in the X-ray they give you, it's like that of soft tissue, but in their own place, they have the bone window where they will detect whether there is a fracture. Okay. Here we give example. We have an example of the soft tissue window. You can see we have two pictures here. Hafiz, are you able to see the two pictures there clearly? Go. Yes. You can see in the soft tissue window, you can see we can see the cerebrum here, the left and right cerebral hemispheres. You can see the falx cerebri in the middle. You can see the gyrus and the sulci here. That is in the soft tissue window that is above. In the bone window, observe the bone window makes all other ones grade and homogeneous. They look homogeneous, and then only the bone appears. Therefore, you can easily see whether there is fracture in the bone or there is no fracture in the bone. But in the upper window, you now see the sulci, you see the gyrus, you see the gray, matter. Okay. The next is the density of structure. Yes, one very good thing that those people reading X-ray or those people reading CT scan depend on is the density of structure. If there are two structures and the other one looks as if water has poured on it, is a bit darker, small compared to the other one, it means something. If one appears more gray than the other one, there is something. If one appears black, there is something. If one appears white, there is something. Therefore, the density of structures are very, very important. It's what actually gives the CT scan edge over the X-ray. Like, for example, they say the CT image generation is dependent on variable attenuation of the X-ray beam. What they mean here is that when the X-ray beam is passed through the body, the rate of absorption and attenuation of attenuation of the X-ray beam is not the same in all tissues. The rate at which the water in the body will attenuate it is different from that of blood. The rate at which the blood will attenuate it is different from that of soft tissue.
And then the highest attenuation is in the bones. And then when you have a metal in the tissue, it has the highest, more than all other tissues in the body. Therefore, it tends to be, then that is where you have a very big artifact. It will appear more than any other tissue. Therefore, we have the bones and skull are very dense and they attenuate large percent of the beam. Therefore, we are going to see that later. Then we have what you call the attenuation value and Hounsfield unit. What we mean by this attenuation value is that, please, this is important. Physiotherapists are trying to read CT scan. At times, we think that the radiologists are producing magic, something you cannot see, but they'll be able to say that this is what is happening. At times, what used to help them is this Hounsfield value, HU values. Yes, if a tissue has a certain HU value, by seeing the HU value and you know that this is where the tissue is, and you know an infection in the tissue, you know it must be that tissue. Therefore, different tissues have different HU values. Therefore, as the beam is attenuated through the body, through several studies, they have come to realize that each study has a value. Each tissue has a value, an attenuation value that is apparent in either the what do you call it, the CT, or in the machine, or in the software that is used to visualize the CT. Therefore, if it's in the software that is used to visualize the CT, it will show you the HU value, or on the CT straight. Therefore, this helps a lot. They said the Hounsfield units of water and air are 0 and -1,000 respectively. The Hounsfield unit of soft tissue ranges from 10 to 50, but I have seen literature that says Hounsfield units of tissues can range from 40 to 80. No matter what it is, the Hounsfield value is above what do you call it, 1. Then fat has negative Hounsfield value, and then bone is what do you call it, the least, with 1,000 Hounsfield value. Can we say it has at least 1,000 Hounsfield value? Is the highest. Actually, is the highest deflector of the X-ray beam. Therefore, it has the highest, and it appears white more than any other tissue. Therefore, what is the relevance of these Hounsfield units? In practical time, with window at 30 Hounsfield units, any number above 70 will appear white, and those that are below -10 will appear black. But the most important thing we should know is that these Hounsfield units help us to identify some tissues. If it is water, it has a certain Hounsfield unit. Then if the value you got is not within the range of water, this is no water. Therefore, this information may not be readily available to us reading what do you call it, reading the CT scan, until when it appears on the CT scan, or you really know that this must be water, this must be what do you call it, blood. It's very, very important to understand the Hounsfield unit. Okay, the cerebrospinal fluid has similar attenuation value to water, and they appear black, meaning that on X-ray, you know the tissues that are supposed to have cerebrospinal fluid in them, like the what do you call it, 2 lateral ventricles in the brain, like the third ventricle in the brain, like the fourth ventricle in the brain, like the sulcuses that are, meaning that the gap between the two the gyri, all these places appear black because they contain cerebrospinal fluid. Okay, then tissue characteristics in CT. These are also very, very important. How do we now differentiate tissues when we see them in CT? They say the cortical bone appears white. We said this has the highest attenuation value. Therefore, when the brain is subjected to CT scan, the calvarium appears white. It looks different from all other tissues. That is clear. Then we have air within paranasal sinuses, air within the chest. All these ones, they have low attenuation value. Therefore, they appear black. Then we have white matter. It has slightly lower Hounsfield value compared to the gray matter, and it appears slightly darker. Therefore, when we are looking at next, we are going to look at the normal, what do you call it? The normal CT. In the normal CT, actually, the periphery of the brain is what is the gray matter. Unlike in the spinal cord, the white matter is outside and the gray matter is in the middle. That is the spinal cord. In the spinal cord, the gray matter looks like head shape, and the white matter covers it. But in the brain, the gray matter is superficial, and then the white matter is located in the core area. Therefore, you should be able to see that the core area appears a little bit darker because they have lower Hounsfield value than the outside gray matter. Okay. The next is what do you call it? Intracranial pathologic condition can appear either dark or bright depending on a particular abnormality. Like for example, if you have acute hemorrhage appears gray, appears lighter than gray, small. It's like almost white, but and it's not homogeneous. Then when you now have chronic hemorrhage is not white. It's like it's becoming with time, like after 2-3 weeks, it's going to become hypodense, almost the same density with the normal tissue, but you can easily also differentiate it. The next is acute intracranial hemorrhage. We said it looks very bright. Acute infarction with low attenuation looks a bit darker. We are going to see all these ones in the pathologic X-rays. In the pathologic X-rays. Then the next is the contrast. Now, why do we use contrast? We said we use it to be able to what do you call it? Spot some abnormalities in the brain radiographs that are not very apparent. Like for example, neoplasm, a cancer, or an infection site that produce induration, like cerebral infarction, areas where there is ischemia. At times they may not, one may think it's an ischemia, but it may not be ischemia, probably it's a neoplasm. Therefore, when a contrast is applied, that place will appear more delineated. The tissues that are infected will look more, pronounced. That is the contrast. Therefore, it also uses what we call contrast. We have another picture here. We give example. We have two, CT output here. The first CT output is taken pre-contrast, and the second CT output is taken post-contrast. You can see in Hafiz, can you see my hand moving? It's not sharing. Is it sharing? Can you see this one? Yes. Can you see
Okay, sorry for the delay. Still the net. Can I share it? Okay, as we are discussing earlier, can I share it? Okay, as we have said earlier, the look at the contrast, what do you call it? Slide. If you can you see my hand movement? Yes. This area where there is what do you call it? Dark cycle, and another area where there is dark cycle. Here in the middle is what do you call it? Two lateral ventricles. They appear black because of the cerebrospinal fluid. They look not very differentiated, but in the post contrast, you can see the area is now well differentiated with a cycle of white, what do you call it? White ring across it, showing that there are lesions around that side, neoplastic lesions. Then the next is image artifacts. When we are talking, I think we were discussing artifacts before the network went off. Artifacts are actually they are visual impression in the image that does not actually exist in the tissue being imaged. What they mean is that there are some impression you see on the image that looks dark or bright or very bright. They are not coming from the tissue. They are coming from somewhere. You said they have to be recognized in order not to be confused with any pathology. The causes are scanner malfunction, movement. When they say the patient should not move, stand still, or take in deep breath, or breathe out, the patient should just do it and not move. If not, artifacts will be what do you call it, generated. Or when they ask individual to remove what do you call it, something from his pocket or anything metallic from the body, it can cause what you call artifacts. Many artifacts are now being reduced or eliminated by advances in speed and technology. But it's very, very common to see artifacts in what do you call it? In CT scans, and physiotherapists reading it should be able to identify this as an artifact or this is the real pathology. Okay, we have motion artifacts. Example, we said we have motion artifacts. The motion artifacts are actually as a result of involuntary or voluntary motion of the persons. Let's see this picture. Can we see the picture? You can see artifact as if there is some painting, light painting on top of the what do you call it? On top of the output. That is what you call artifact. It's not as a result of tissue injury or anything. Those things that looks like white superficial paintings are artifacts that are due to motion. You ask somebody to stand still. The patient was rotating the head from left to right. Then he gets artifact. The black something you see in the middle is the, what do you call it? Is the two lateral ventricles.
This one is telling you that this guy is an elderly person because the lateral ventricles are big. Therefore, if it is a small, if it is a child, the lateral ventricles will be very small. Then we now move to the next artifact, which is metallic artifact. Yes, we said metallic has attenuation factor greater than all the tissues in our body. Therefore, if it is being viewed, it will appear so whitish. It will like reflect on all the tissues. Just the way we said, the bones actually have the highest attenuation factor in our body. They appear more whitish than any other one, but any other tissue, then metal has more attenuation factor than our tissues. Then let's look at, this is what the metal look like. Somebody is having a metal in the head or something and they took the x-ray, you can see how the metal shines all over the place. Therefore, it has to be removed and retaken again. This is an artifact. Then we have beam hardening artifact. In beam hardening, there is a way, there is what in radiology, there is what they call dosimetry. What is the dose that is required? What is the dose that is required for each of the what do you call it? The CT scans they are taking. Therefore, if the dose is too high, then we now have what we call beam hardening artifact. An area that's supposed to look bright or gray will now look dark, as if it is water, or as if it is cerebrospinal fluid, or as if it is having any pathology. Then it is beam hardening artifact. We give example. We have the one below here. You can see two arrows here. Two arrows around the area of what do you call it? The brainstem. It is not actually as a result of pathology. Those two arrows are pointing to a dark area that appear on a gray area. Just a dark area, small at the tip of the two arrows. They said is a beam hardening artifact. In conclusion to the introduction, we have said that images are obtained from CT by rotating the X-ray beam or by the rotating X-ray and detector beam system. The second one, we said it allows for it has an advantage that it allows for relatively quick assessment of intracranial content in order to see neurological deficit. We also said that CT differentiate between tissue based on their densities, or what you call the Hosfield unit. Therefore, it's one of the things that actually gives the radiologist ability to be able to detect more tissues because of the Hosfield unit. Okay, we said the CT is an excellent modality for screening cranial trauma, suspected intracranial bleeding and stroke. And that is the end. We say thank you for listening. Therefore, this first slide is for introduction to computed tomography. What is it all about? What is the advantage of using the CT? What are the, what do you call it? The different Hsfield units based on the attenuation of, what do you call it? The beam by it. What are what you call the artifacts in the CT? Therefore, we are going to look at the next presentation. Because of time, we have wasted time trying to see secure connection. Then Hafiz, the next go. I unmuted myself. Okay. Hope you are with me. Hello.
Well, with you,
Hello.
sir.
Okay. We are done with the introduction, and we said we are going to study the normal computed tomography, study of the skull and the brain. And one important thing we should note is that for us to be able to spot the abnormal, we have to revise the normal. And the normal is not just the anatomy, it's CT anatomy, please. CT anatomy, not our normal anatomy, but CT anatomy. We have to revise it such that at the end of this lecture, if a CT slide come to us as physiotherapists, we should be able to say, I am thinking it must be this. Probably you may need further clarification, or you should be able to say, I am certain that it must be this. That is the aim of this lecture. Therefore, we have done the first part, introduction to CT. Therefore, when we talk about artifacts, we know it. When we talk about beam hardening, we know it. When we talk about hospital units, we know it. When we talk about all other things that we have introduced. Therefore, we are talking about the normal study now. Remember, we said there are two windows in the CT. We have the bone window and we have the soft tissue window. Anyone that the radiologist want to use, he will use them. Because if you use the bone window, he would want to see fractures. Where the bone alignment, you would want to see whether there are the continuity of the bone and everything, the quality of the bone, whether there is osteoporosis or anything. If you want to see the soft tissue, you want to be able to differentiate between all soft tissues based on their Hounsfield units. Here, we are going to discuss the normal computed tomography under some subheadings. The first subheading is we want to look at under the skull, we want to look at the skull bones and the sutures. We want to look at the cranial fossa, meaning that the base of the brain, where you have the anterior fossa, we have the posterior fossa. Remember the last week when we are discussing childhood, cancers, we are discussing posterior fossa tumors, we are discussing supratentorial, infratentorial tumors, all those ones, they matter a lot. Then we now cranial fossas, skull sinuses, our paranasal sinuses, the ethmoidal sinuses in the forebrain and all these guys. Then the orthogonal planes. What are these? The axial plane, the parietal plane, the sagittal plane. Is the X-ray taken in sagittal? Is it taken in axial, or is it taken in corona? Then what are all these planes? They are very, very important. Then the next, we are going to look at the normal brain CT. In the synopsis, image orientation. How do we know the head and how do we know the skull? How do you know right and left? How do we be able to get this? Then we will now see the meninges, the dura mater, the arachnoids, and the pia mater. Because if we don't know it, then we are likely not going to be able to say this is extradural, subdural, and subarachnoid hemorrhages for individuals with head injury. Then we are going to look at this cerebrospinal fluid and spaces. We are going to look at the gray and white matter, cerebral vasculature, the areas that are supplied by anterior cerebral artery, middle cerebral artery, posterior cerebral artery, vasculoarterial artery, perforating artery arriving from the middle cerebral artery. Then the brain volume. I want to say this child or this father of mine has lots brain volume. How do we now detect that this brain, actually there is a reduction in brain volume, or there is a small brain volume in this guy? That is very important. Then we now go on with the skull. We have about 45 slides that we have to keep rushing. We have the skull, and the skull we said have around 6 bones. We have frontal bones like the ones in our forehead, bushi in Hausa, forehead. Then parietal bones that are following them as you are coming back. Then we have the occipital, the one at the tail back. Then we have the ethmoid bone, they have the sphenoid bone, and the temporal bone. The temporal are the ones that are very close to our ears, the temporal bone. Then we can have them. The frontal bone is number 1. We have the parietal bone is following it up. Then the occipital bone is at the tail end, is our occiput. Then you can see the temporal bone is around our ears. Then we have the sphenoid bone. Then the next is we have the sutures. we have the corona, we have the lambdoid, where I actually give them blue, green, squamosal, and sagittal. Look at it here. The one that is blue is corona. Then the one that is in the middle, that is purple, is what you call, sagittal. Sagittal meaning that it divides you into two halves. As you are standing, something divides you into two halves. Your left hand go separate way, your right hand go separate way. You are divided sagittally. Then if it is corona, it divides you such that, the front part of your head and will go, the back part of your head will go back. They divide you that one. Then these ones are what you call the sutures. The coronal sutures, you can see each one has its color. The squamosal suture, the sagittal suture, the lambdoid sutures. Those ones are the sutures in the brain. Then we now have the cranial fossa. The cranial fossa are the ones that actually house the brain. They are the base, they are found at the base of the skull. They are the ones that houses our brain. We have the anterior fossa that houses the anterior part of the frontal lobes. The middle fossa houses the temporal lobes. The posterior fossa houses the cerebellum and the brainstem. And pituitary fossa houses the pituitary gland. Usually the pituitary fossa is in the middle because the pituitary gland is the middle. Posterior fossa is behind. Middle fossa is in the middle, and anterior fossa in the front. Just like the way we have it here. We have anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. Meaning that where we have, like in pediatrics, where we are discussing the posterior fossa tumors, we are talking about tumors affecting cerebellum and and medulla oblongata, and all these guys are the posterior fossa tumors. Then we now have the skull sinuses. That is where we have air spaces. Remember, we said air spaces in the brain appears black. Air is black in CT. That is why, because of the attenuation value, it's black. Therefore, you can see ethmoid air cells, and then you can see the ethmoidal bone is black. We have see the mastoid bone. You can see they are also black. Then the next, we keep moving because of time factor. Then we have what we call the orthogonal planes. These planes are very, very important in MRI. They are very important in X-ray. They are very important in CT. We are discussing CT. Please, there are pictures, there are outputs of CT that are taken usually in corona, in the axial plane. And then what do they mean by axial plane? Look at where my cursor is. Can you see my cursor? The axial plane is the one that is red in color. The one that actually is like removing cap from your brain, from your head. Just is like, the axial is like, let's say, transverse. The way we used to have transverse plane. The axial is like that. It's just removing cap from you. Just like, say, divide you into two halves. Your legs will go down and your trunk will go up. When they divide you into two horizontally, that is the axial plane. And usually most of the CTs that have been analyzed are analyzed at the axial plane. It is as if you are looking at the head, you climb up and you are looking at the head of somebody from up. That is how you visualize the brain. That is axial. Then you can see corona plane. In corona, it's as if you stand up. When you stand up, you are facing the wall. Somebody will now divide the head into two, but actually around your shoulders. The blade will now move from the end of one shoulder to the other one. Therefore, it's like your head, your face will go forward, and your skull, your occiput will go backward. That is the corona plane. It is the plane is around your shoulders. Therefore, the orientation of the plane is around your shoulders. Therefore, they divide it such that the front part of the body will go and the front and back, meaning that it will divide it into what? Front and back. Then in corona plane, it's like removing cap from you. Somebody can see the top, or dividing you into lower limb and upper limb. It is horizontal. Then we now have the sagittal plane. Look at the sagittal plane is in yellow. You can see it. Sagittal plane is in what? Yellow. What is that one? The sagittal plane is like you are standing. But this one is, it will move from back to front, divide you straight, such that left hand and right hand will be divided. That is a sagittal plane. That is a sagittal plane. For example, the picture here, where you can see my cursor, is taken in sagittal plane. This one is in sagittal plane. It's as if the individual is standing and you divide him into two, such that left and right hand are apart. Then the one here, where you can see my cursor, is the one is taken in one axial plane. It's like they remove cap, they remove the calvarium. You can see the brain structure. And the one here is in coronal plane, where they divide him such that is divided into the front part of the body and back. They divide it into two. That are the planes. Okay. Then we have normal brain city. We now begin to look at the brain city. We are done with the bones. We are done with we are done with the planes of the body based on the CT images. Brain orientation. The orientation of the brain is usually sagittal, meaning that if they are taking any form of CT, the first is sagittal. It is later when they are unable to get clear view of some structures, they will now say, okay, let's go corona, or let's go axial or so. This is a mistake. This is axial. Okay, now they said images of the brain are conventionally viewed from below, as if one is looking up into the top of the head. Then this means that the right side of the brain is on the left and the left is on the right. The anterior part of the head is on the top of the image. What they mean here is that if an X-ray, if a CT is taken this way, you can see the top part of the brain is anterior and the other one is posterior. It means as if you are looking, either you climb on top and you are looking at the brain when the skull is removed, or you are looking from behind and you are looking at the brain up, such that where you are looking at, the top part of it will be anterior and the other part of it, this is the posterior. That is where the occiput is. And then here on the X-ray, on the CT again, what you are seeing on the right is actually left. What you are seeing on the left is right. In essence, where my cursor is here, its orientation is left. Where you are seeing here, the orientation is right. In essence, the top part of it is anterior, the one behind is posterior. Then where my cursor is as I'm moving is what? Left, and here is right, meaning that the right and left are opposite to what you are seeing, just like the normal anatomy. Then we have the meninges. The meninges are three actually. We have dura mater. The dura mater is actually coming immediately after the bone, the skull is attached to the bone of the skull. They are only differentiated by a pathology. Then we have arachnoid. The arachnoid is also attached. They are one unit with dura mater. It is only pathology that separate them. But the pia mater is actually different, is a bit far away from the arachnoid and dura mater, because in between the pia mater and arachnoid, there is what you call the subarachnoid space. In that subarachnoid space, you can also have hematoma consolidating, because that pia mater is actually very close to the gyri. Okay. Therefore, dura mater and arachnoid are anatomical units only separated by pathological process. Here, okay, can you see these pictures? The first one is the CT, the normal CT we know. And the second one is the CT where all the individual structures have been explained. The one in the middle, the white one in the middle here, where there's, we have the facts. The facts actually run, is part of the meninges, that runs actually across the entire brain. Therefore, it's a fact. And it's very important when you are looking at mass effect, whether there is shift, there is edema in one place, and structures from the left have shifted towards the right. You look at the facts. If the facts cerebri actually they're supposed to be very straight, actually has become rounded, there is mass effect, either due to edema or anything. Then look at it. The first one is the what do you call it? Is the bone that appears white. The one in green is the dura mater. It's very strong, attached to the bone of the calvarium. Then we have the arachnoid attached to the dura mater. But actually, the pia mater is the one that appears yellow. The green is the subarachnoid space, where you have subarachnoid hemorrhage. Okay, then we have what is the clinical relevance of this meninges? They said knowledge of anatomy of meninges is essential for understanding the CT appearance of intracranial bleeding. And actually, when we come to intracranial bleeding, I think they are the simplest to recognize. If you understand the crescent shape, you understand the convex shape, you understand all these things, then you are done. Then we have the falx cerebri and tentorium cerebelli. The active folding of the meninges that are visible on CT imaging. Yes. Therefore, when we talk about tentorium, we are going to see it. It's actually, you can have the supratentorial and infratentorial tumors, the way we discussed. Falx cerebri, we have seen the falx here. The one that runs into the middle. It goes down to the other end. Therefore, it's also very important when there is shift in the falx cerebri, something is happening. There is a what do you call it? Midline effect. Okay, you can see facts here. The facts run across this, and then when there is shift in the facts, then something wrong is happening, most especially mass effect. Then we have tentorium cerebelli. You can see here, it has been taken in such a way that the tentorium, there is something I also want you to understand. There are so many slides of the brain. When you take a slide, like there can be 100 slides of the same brain, and they are axial, all of them. It does not mean that when you take the first slide, it must look exactly the same with the second slide. As you are going deeper, other tissues will now become apparent. That is why when you are reading CT, when you read the first one, you couldn't get anything, read the second one, because as you are reading the slide, some of the structures will now become more and more visible. You should be able to see what you want to see. Therefore, the first one where we see the facts is more superficial than the other one. This one is deep. You can see the brainstem. You can see the, what do you call it? The cerebellum, and you can see the tentorium cerebelli. Okay. Okay, let's move. Cerebrospinal fluid. Remember in our previous slide, we said cerebrospinal fluid are contained in cerebrospinal spaces. Usually they are contained in the two lateral ventricle, foramen of Monro, in the third ventricle and the fourth ventricle. Those places supposed to appear dark and black because of the attenuation factor of the cerebrospinal fluid. Therefore, the appearance of this allow us assessment of brain volume. Yes. Okay. When we come to assess brain volume, you now see the difference between the brain that has normal volume and the brain that lost blood volume. Where they are in good spaces, enough spaces, large spaces between the sulcus and the sulcus and the what do you call it, gyrus, and they appear black, meaning that we lost brain volume. Where there are small spaces, the dark spaces are very small, the brain volume is still there. And we said CSF is lower density than the gray matter or white matter and appears dark in CT images. We have said this. Then now, what are they? We said they are contained in the two lateral ventricles and the third ventricle. The two lateral ventricles are where the cerebrospinal fluid is produced, and then inside, in the lower end of the two lateral ventricles, we have the choroid plexuses. They are the ones that produce the cerebrospinal fluid. We have the third ventricle that is located centrally. The other ones, just like your two noses, the other ones are located centrally, but they appear. Each one of them is facing the other one, like your two fingers. Then the other one is in the middle. Okay. I will show you. Let's go to the ventricles. Okay. Can we see? Hafiz, are you with me? Can you see the movement of my cursor? Okay. Please, if you can see the movement of my cursor, look at the two lateral ventricles as if you raise your two fingers. These are the two lateral ventricles. This is telling you that this individual is a young individual. If it is an elderly person, the lateral ventricles will be very big. we are going to see the ventricles of an elderly person. It looks very big, but this is a young individual. The ventricles are small. Look at the other one. This is the third ventricle. The third ventricle is also dark. The fourth ventricle is not very apparent in this place. But these are the two lateral ventricles. This is the third ventricle. As you can see in the other picture, we have foramen of Monro in between them, the two lateral ventricle and the third ventricle. Then the sulcus and gyrus. Please, this is very, very important. Please, this is very, very important. Where there is an effusion due to edema in the brain, it is only the sulcus and gyrus that will tell you that there is an effusion here. Something wrong is here. When the sulcus and gyrus are completely missing, how do we utilize the sulcus and gyrus in actually reading this X-ray? They are CT. They are very important. Let's look at the sulcus. Look at the sulcus is a fold. It's a fold of the brain surface. Therefore, when you put your two hands together, the gap between the two hands is the sulcus. Then what are the gyrus? These your two fingers, the convolution that the two fingers that look round. The two fingers that look round are the gyrus. And the sulcus, when you put your two fingers together, just like the way we have it here, just like the way we have the two lateral ventricles. If you put your hands here, the two hands that are together, they look like more of, because they are roundish, they look like more of the gyrus. And the space between them is the sulcus. Therefore, this is what is happening. What we have here, you can see the sulcus here in the picture, and look at the gyrus here. The gyri are usually convoluted. They look just like your intestine. The way the intestine is, they look convoluted. But in between them, you see the sulcus. In between them, you can see this dark place. The dark place is the CSF. Hope we are understanding. Then we now move to the gray matter. Then remember we said the gray matter is superficial, meaning that it's on the outside, and the white matter is in the middle. But in the spinal cord, the white matter is on the outside and the gray matter is head-shaped, is in the middle. This is we need to understand. Then what are these gray matter in the brain? The superficial gray matter is the cortex. Then we have the insular gyrus. The insular gyrus, when we look at the picture, it's just going to look like 3. The way you write your 3, 1 to 3, 1 to 3, it's just like that, very close. Then we now have the basal ganglia, and the insular gyrus is actually associated with balance. It's associated with coordination. Then we have, what do you call it? The basal ganglia. I'm going to show you how we easily recognize the basal ganglia and the thalamus. Then we now have the cerebral cortex. It's the layer of gray matter that form the gyri over the entire brain. Then let's go and see the picture. Okay, this is the picture of the gyrus. Okay, I want you people to look at this particular, the one that has no color. Look at the one that has no color. The middle part of it looks a bit different from the outside part of it. The middle part of it looks like the mouth of a dog. And Hafiz, go back over. Looks like the mouth of a dog. We have 2 here where you have my cursor. Looks like the eye of the dog. The 2 black, what do you call it? Internal or 2 lateral ventricles looks like the nose of the dog. Is that also? Okay, they are very important landmarks. You can always read it through this way. Look at the one that looks like 3. Can you see it here? Is the insular cortex. That looks like 3 is the insular cortex. Okay, now let's begin to look at it. Can you see the lips of this dog? Can you see it? You can see a dog with 2 lips. Is that also? The lips of the dog are what you call the what do you call it? The relay center for all sensation. That is what do you call it? Thalamus. This is what? Thalamus. This is what? Thalamus. That is the relay center for all sensations. When you go up, can you see something very close to those particular things that look like air, the 2 lateral ventricles? This is what you call the lentiform nucleus of, what do you call it? The basal ganglia. You can see it very close to these 2 dark things in a curve. Is that also? Very close. The tissue close to them are what you call the lentiform nucleus. On top of the two, you can see it here. On top of the two that looks like forehead. Cool? This is where we call what we call the caudate nucleus of the basal ganglia. Then close to this one, you can see this space that looks also a depression like this. Can you see it from my movement? That's another place. When we go to that place, we are going to explain. But remember, you can see, look at this mouth of the dog. Can you see some whitish things here in the mouth of this dog? Like looks like teeth. The whitish thing, you can see the first one and the second one that looks very white. Cool? That is what you call calcification of the caudate plexus. The caudate plexus of what the two lateral ventricles calcify with time. It is not calcified in children, but it is calcified in what? Adults. Therefore, whenever you see calcification, either it is either blood or it's an adult. Altogether. Okay. Now, you can see, now look at it. Where you have this particular green area, can you see? This is where we call the gray matter. The ones that are inside are called what? The white matter. Then what are these gray matter structures? We are going to see them one by one. Okay, we start with the insular cortex. Remember we said the gray matter is on the outside, the white matter is in the inside. Is that also? And we can see the green that depicts what? The gray matter. Cool? Then we now see the insula. We said the insula is very, very important. It's from the inner surface of the cerebral cortex deep into the sylvian fissure. What is the sylvian aqueduct? You know the sylvian aqueduct is the tube that connects the two lateral ventricles. Is that also? Therefore, they are telling you that this one is inside, is very close to the sylvian fissure. Therefore, we have the clinical relevance of the insular cortex. We said loss of definition of the insular cortex may be an early sign of acute infarct. Therefore, when you are looking for insular cortex and you cannot see it, it is telling you that there is likelihood of having an infarction. Infarction meaning that there is ischemia and death of tissue in that place. That is and another way of reading X-ray and CT. You know the exact location of a particular what do you call it, brain structure. But due to some edema or blackish something you cannot see, that is to tell you something is wrong in that place. They said injury to the insular and parietal cortex is associated with dizziness. They said inferior frontal and insular lesions lead to problem with whistling, chewing, and orofacial apraxia, meaning that when you move your mouth and you ask somebody to follow you, he will not be able to do it. He cannot whistle, he cannot chew. That is the relevance of insular cortex. Now, look at, we have taken the picture very close now. You can see the picture that looks like 3. You can see the movement of my hand. It looks like what? 3. That is the insular cortex. And remember we said it's what? It's located deep inside. You can see the insular cortex here. It's a deep gray matter. Okay, then the next, we are going to look at the basal ganglia. Remember we told you that the basal ganglia has two, what do you call it? It's a combination of two structures. The lentiform nucleus and what? The caudate nucleus. Okay? And then remember the clinical significance of the basal ganglia, it may result in disorders of movement. What is the common disorder of movement that basal ganglia is associated with? In children is extrapyramidal CP. Is that also? Athetoid, CP, and all these guys. That is, but in adult is what? Parkinson's disease. Basal ganglia is affected. It leads to unwanted movement. Then they said, now, then the thalamus. We are going to look at them, all of them. The thalamus is the relay center for all sensations. Whether sensation of touch, whether sensation of, what do you call it? Touch, whether sensation of, what do you call it? Vibration, whether sensation of vision, whatever. It must pass through the thalamus before it reaches the conscious brain. Therefore, wherever you have problem with thalamus, then you have sensation issues. The biggest example is central post-stroke what? Pain. That is pain that is associated with damage to the what? Thalamus. Then now let's look at the thalamus. I have explained to you. Now look at the dog. In the first instance, look at the first image. That did not look at it. There has no color. I told you the dogs have upper lips. Is that also? Can you see the upper lips? The two upper lips are the thalamus. Are we really understanding? Then we now have, look at it here. Look at the two lateral ventricles here that looks dark. But close to them, I said in the same area, very close to them, having the same curve is what? Is the coded nucleus. Then with them we have the lentiform nucleus. Then these two, the one in light, is it light green? And the one in is it orange? In orange, they form what you call what? The basal ganglia. This one that looks like the lips of the dog is what? The thalamus. Okay, now let's keep moving. Then we now have white matter. What is this white matter? We have the gray matter. Please, what forms the gray matter in the brain? We should ask ourselves, what forms the gray matter in the brain? What actually forms the gray matter in the brain? You know, in a neuron, we have what you call the cell body. In a neuron, we have what you call the axons. Is that also? Yes, actually, the cell body is what forms the cerebral cortex, is the gray matter, meaning that the cell body is on the outside in the brain, but in the spinal cord is what? In the middle. Then, but in the brain, the cell body is on the outside, while the tracks, those ones are the ones that, like the wires that come down from the brain to the spinal cord, they are the ones in the middle. They are what you call what? The white matter structures. They say the white matter lies deep into the brain cortex and includes internal capsules. Yes, for people that are actually managing stroke in children and adults, we know internal capsule. Is that also? When there is damage to the internal capsule, you have stroke. We have corona radiata and corpus callosum. Then we now have superior internal capsules. Superiorly internal capsules connects with white matter of the cerebral cortex and with the brainstem inferiorly. What do they mean here is the internal capsule is like a passage where very big axons of what do you call it? Corticospinal fibers pass through. Therefore, they connect to the cerebellum, the cerebrum superiorly and to the brainstem inferiorly, meaning that they have to pass through it. That is the connection. It's a connection area. Anything that happens to internal capsule, you are likely going to have stroke. Then the corpus callosum is a white, white matter in the brain that is located in the midline. It attaches the two lateral ventricles. It's like a gum that put the two lateral ventricles together. But it has significance. So one thing is that on the negative side, if you have tumor, the tumor will pass through the corpus callosum from one hemisphere to the other one. Then we have falx cerebri. Remember, it also is a fold in the middle. What it does is it restricts movement of tissues, pathologic tissues, and and cancerous tissues to the other side of the brain. It has that advantage. Okay. Then we have the significance. What is the significance of this structure? For the internal capsule, is supplied by perforating branches of the middle cerebral artery, meaning that why we used to have stroke due to internal capsule problem, it's not the middle cerebral artery gong that actually supply it. It is the perforating branch of the middle cerebral artery, meaning that there are small arteries that can be subjected to either hemorrhage or ischemia. Therefore, whatever happens to it, the bundle of fibers that pass through it to the brainstem will now become injured. Then you will now have stroke. Then they said even a small insult to the internal capsule can have profound effects on motor and sensory function, most especially stroke. Therefore, then where is the internal capsule? Now, we have it. Now, look at our structure. We have anterior limb of the internal capsule. We have the posterior limb of the internal capsule. Now, let's go back to our dog here. The first one, if we are relaying, remember, can you see in a lentiform nucleus, the one in, purple, is that also? Can you see coded nucleus, the one in light green, is that also, or light blue? In between them, you can see something that run like inverted C. Is that also? That one is what you call what? The internal capsule. That is what you call the internal capsule. Hafiz, can you see the movement of my cursor? Can you see the movement of my cursor? So that place is what we call the internal capsule. Therefore, it is supplied by perforating branch of middle cerebral artery, and any insult to that area will lead to stroke. Therefore, this is the internal capsule. Therefore, when we come back to this place, you now recognize, I think in this picture, you can now recognize the internal capsule. You can see very close to it is the lentiform nucleus. Very close to it is the caudate nucleus. And then we have the thalamus. Is that also? Then in the middle of it, you have one star. The star is what you call what? The genu. The genu, what we mean by genu is where you have rotation. It's a curve. Where the internal capsule, the anterior limb has a curve, then the posterior limb comes back. Therefore, it connects what it does is it connects the cerebellum to what? The brainstem. The bundle of fibers used to pass through. And if there is any damage in that place, that is all. Any problem with that one? No. We really understood. Therefore, when you understood that the middle part of it looks like the brain and the face of a dog, with nose and everything, you should be able to recognize all of them. Cool? Then the corpus callosum. Here, in sagittal city, what do we say in sagittal city? Like you are standing, somebody will divide you into two halves. Your left hand will go his way, your right hand will go with his way. Like you are looking at the wall, somebody will just divide it into two halves. Left hand goes way, right hand go its way. That is sagittal. That is the best way to view corpus callosum in the middle of the brain. Then it's significant. Malignar lesion can grow from one brain to the other via the corpus callosum. But remember, we said there is another a strong structure that used to resist that, which is the what? Falx cerebrico. Then we now have, look at the corpus callosum. This is like half of the brain that is divided. You can put the other half to close it up altogether. That is half of the brain. That is where you have the corpus callosum. You can see also the corpus callosum has a tone, a tone that like a curve. We call it also the genu. Okay. Then the next is the vasculature. We have successfully looked at the gray matter, some gray matter structures that are important. We have successfully looked at the white matter structures that are of what? Importance. Cool? Then we are going to look at the vasculature. Yes, the vasculature of the brain actually consists of what do you call it? Area supplied by anterior cerebral artery, that is the forehead. The middle cerebral artery that supplies most of the lateral part of the brain, and then we have the posterior cerebral artery that supplies the occipital part of the brain, and we have basilar artery that supplies the bottom of the brain, and we can have all this one, the perforating arteries that supplies or the areas of the internal capsule and the rest. This is, then now we have, look at it, ACA. The one at the top is anterior cerebral artery. That is the region of anterior cerebral artery. Then we have MCA. That is the region of middle cerebral artery. You can see the insula is very prominent here. The one that looks like three. Is that also? Then you have, what do you call it? Middle cerebral artery area that is supplied by perforating arteries. You can see it. It looks like purple. Is that also? Look at it. That is the area where you have what? Basal ganglia. That is the area where you have, what do you call it? Lentiform nucleus. That is the area where you have thalamus. That is area where you have internal capsule. Is that also? That is the middle cerebral artery. Therefore, damage area. Then you have posterior cerebral artery. You can see the posterior cerebral artery lesion. What do you call it? Area is around the posterior fossa. Then the brain volume. What is this volume? And we have said it. When you lost a lot of brain tissue, there are so many spaces between the gyri and the sulcus, then you lost brain volume. Then they said brain volume is assessed by estimating the relative volume of the CSF spaces. The ventricles can be very small in young adults and very large in the elderly. Okay, now look at it. We have said it. Look at the picture here. This is the ventricle of a 10-year-old. You can see it? The ventricle look very small. And you can see the way it is now colored light blue. Is that also? Then you can see the ventricle of the old person. If it is like this in a young person, then we said that the guy is likely going to have what? Hydrocephalus altogether. But look at it, the ventricle of the young person is small. That of the elderly person is what? Is big. Then look at what is happening in that particular area. Look at the first that of 90-year-old. You can see the gyrus. What do you call it? The gyrus becoming smaller and the sulcus becoming bigger. Is that also? Meaning that this elderly person has started losing what? brain volume. You can see in the green, you can see large, what do you call it, sulci. Now they have painted the CSF fluid green so that you see that they are large. But in a small person, hardly can you see them. Is that also? Meaning that the brain volume is more pronounced in the young than in the elderly. The elderly lost brain volume. And they said, most especially people with Alzheimer's disease, most especially people with stroke that are not doing exercise, most especially people with Parkinson's disease, they are likely to lose what? Brain volume. Okay. Therefore, loss of brain volume leads to what? Large ventricles, leads to large, what do you call it? Sulcus, leads to large and small gyri. The gyri will become what? Smaller, and the sulcus will become what? Big. CSF space will now become bigger. That is the loss of what? Volume. Then we now have calcified structures. When we are viewing CT scan, you are likely going to see some calcified structures. They look normal in the elderly, but in the young, it's not normal. Some calcified structures in the young may actually signal that there is hemorrhage in that area. Then what are these calcified structures? Remember we said the dog has 2 teeth. That is all that we see. Those 2 teeth are what you call the choroid plexuses. In the elderly people and the people that have grown up, it starts to calcify, meaning that less CSF is produced in the elderly compared to children. That is why they are prone to hydrocephalus when the CSF is blocked, because they produce a lot of what? CSF. But for us, it has started calcifying. It produces less and less CSF as we grow. That is why a child will fall down and will not have head injury, because the brain is really cushioned by a lot of what? CSF. But for us, little head injury will take us to the hospital because we produce less CSF. Therefore, let's look at the dog here. Can you see the first 2? The ones that looks like teeth in the face of the dog. Is that also? These ones are the choroid plexuses. In the elderly, it's calcified. In the young person, when you see 10-year-old and you see calcification, it's likely going to be a hemorrhage in that place. Okay, then look at it. Can you see the two lateral ventricles from my cursor? Can you see the third ventricle? They are connected via foramen of what? Monroe. At the tail end, can you see one calcification in that place? That is what they call pineal gland. It also calcified when you grow up. When you see it in a child, then it is not normal. Then, can you see some 2 eyes in that place? Look at, it's the same face of the dog. You can see the 2 lateral ventricles, you can see the third ventricle. But around this place, remember in front of it, you can see the internal capsule here. But you can see the lentiform nucleus, the 2 lentiform nucleus are here. So these 2 lentiform nucleus are the ones that calcify. When you are growing, the 2 lentiform nucleus are likely going to calcify. If it is in a young guy, when you see it, then it's likely going to be a problem. It's not calcification. If it is an elderly person, then it's likely going to be calcification of what? The basal ganglia. They say they are calcified structures, meaning that naturally as you are growing, they are going to calcify. But if it is not them, then it is a sign of hemorrhage in this place, most especially acute hemorrhage. Then look at this guy. Falx cerebri. What is this falx cerebri? Remember we said falx cerebri is an extension of what? The meninges. Is that also? The 2 meninges, most especially that fold, we said that it goes round, it passes across, it shares the brain into 2. We have left and right hemispheres. Is that also? Look at what they say here in this elderly. Look at the spaces here. By seeing this big small gyri and big spaces, you know this guy is an elderly person. Is that also? Yes, if it is a young person, you are not going to see this big sulcus. You are only going to see big gyri and very small sulcus. And then look at this one. They are telling you, is it blood? It's no blood. And then you can see the bone window. Remember we said there is tissue window and bone window. You can see the bone window is telling you that this is a bone. Meaning that for a radiologist to tell you whether it is blood or anything, he will now go and resort to bone window and see whether this one is bone. Then the bone window has confirmed that it's what? A bone. Then what is this bone? It has calcified. This is what we call falx cerebri. The falx cerebri that is going down with time is going to calcify. Altogether. That is why we said it can also prevent the movement of what do you call it? A pathologic tissue or brain tissue that is having let's say a tumor or anything, to move from the other side altogether. It has that advantage. Then, by conclusion, we said it is important to know the normal brain structures in CT scan in order to easily identify the abnormal. Thank you. This is the end of the second presentation. The aim of the second presentation is for us to understand the way, what do you call it, the brain structures are in a CT, how we easily identify them, such that when we have a pathologic finding, we should be able to say this is something. And we believe that at the end of this particular lecture, a physiotherapist actually that is in this forum should be able to pick, what do you call it, any CT and make meaning out of the CT. Thank you. I'm going to go to the third presentation. I stop sharing. Okay, thank you very much for listening. We are going to the third presentation. Okay. Okay, now this is the final presentation. When we are looking at, we have now, before now we have seen normal brain CT. Okay, we can say normal study CT. CT that is looks what? Normal. And we're able to see brain structures, we are able to see the thalamus, we are able to see the falx cerebri, we are able to see the lentiform nucleus, we are able to see the caudate nucleus, we are able to see the internal capsule, we are able to see so many things. Therefore, we have known the normal. How do we now see the abnormal? Thank you for listening, and we are moving to the third slide. Okay, by revision, we suggest systematic approach to interpretation. Meaning that we want to revise what are the things we need when we are revising a CT, more especially brain CT. Is it that of a child or that of an elderly person? What are we likely going to see? Then they said there is a guide, and we said we should use systematic approach to interpretation. What are these systematic approach? The first thing you see, let me remind you the name of radiographers. They call them clinicians with eagle eyes. They said they will show you, what do you call it, a CT. But you will not be able to say this is what is happening. But a radiologist will tell you that this is what is happening. Are they producing magic? They say no. They are using a systematic approach to interpretation. They are using the host field, what do you call it, units to know which tissue is likely. They know where the tissue is. They know the host field unit. It is likely going to be this. That's one. Two, there is systematic approach to interpretation. What and what are they looking for? And then what color and what color are they looking for? The first one is the symmetry. All the slices comparing one side with the other. Therefore, you now can get 3-4 slides of the same, let's say, corona plane. 3-4 slides, the deeper are going to give you clearer view. What is the symmetry? The falx cerebri is in the middle. This is the falx cerebri. Okay, I have gone to another slide. The falx cerebri divide the two hemispheres into two. Okay, now, is the falx cerebri straight? No. It is shifted, meaning that one place is edematous, it has shifted, it has been bulged into another, meaning that symmetry is lost. If the falx cerebri cannot be seen, can you see evidence that there is shift from one side to the other due to either edema or intracranial space or occupied lesions such as masses or anything? Then if there is asymmetry, then something is wrong. The second thing is blood. Acute hemorrhage appears hyperdense. Usually it has 50 to 100 hospital units. Okay, what is hyperdense? It appears whitish, but it's not very, very white. It is not as white as the bone, but it appears whitish. That is acute hemorrhage. Because chronic hemorrhage is hypodense. It appears almost like the tissue. You need to compare the two something before you understand it. Usually they say it's tricky to understand the chronic hemorrhage. Then you can see acute hemorrhage, it appears hypodense, meaning that from the A we have the B is blood. You should look for the possibility of getting blood. If there is no blood, then you should look at the brain tissue. Remember, we have the white matter and the what? Gray matter. Look at all the structures in the white and gray matter carefully. Can you see hyperdensity? Then it is likely acute blood. Or in some instances, tumor, in some instances, whether it is bone. Remember, hyperdensity, bone appears white. Is that also? Or it is likely going to be a contrast that is applied in order to see the sides of something. Or it is likely going to be a foreign body. Example of foreign body is an iron. Is that also? Then if it is that thing, then you should be able to look at that one. Then hypodensity. Is it edema? The edema and infarct, meaning that infarction like ischemic stroke, looks what? A bit dark. It looks like water drop in a particular place that looks a bit darker than the other side. That is it. Or is it an air? If it is an air, it will be black. Then if it is tumor, it will just be like an infarct. But if it is air, it will be what? Black. Then that is it. Then we are revising our systematic approach. Then we said ischemic stroke or infarction is hypodense and hemorrhagic is what? Hyperdense, most especially the acute ones. Then we have C. They say we should look at the CSF spaces. Okay, systole, sulci, ventricles. Can you look at the ventricles? Do they enlarge? If it is in a small boy, enlarge, we know it's hydrocephalus. If it is in an elderly person, we see the gyri becoming small and the sulcus becoming wide. We know there is loss of what? Brain volume. Then we now said we assess that of the ventricle sulci in proportion to each other and brain parenchyma for brain volume. You identify normal systems and fissures. They are all important. Then we should also assess the scalp for what? For soft tissue injury, meaning that holistically you should look at this particular acronym ABBCS. A for what? Symmetry or asymmetry, where there is deviation in the falx cerebri. B, blood. Check the brain for hyper and hypodensity. Then we should assess for what? For the scalp for what? For injury. Then we should assess for what? Cerebrospinal fluid. Cool? That is what they said. We should assess for cerebrospinal fluid, CSF spaces, assess for scalp for injury. Then now, we are now taking each one of them, the ABBS. When we are done with the ABBS, by God's grace, we should be able to say, we as physiotherapists, when we take X-ray, we should look at the bone window, we should look at the brain window. At times, the radiologist may not give you the bone window. It is just meant for his consumption, but he may give you the brain window. Or at times, they may come with them. You should be able to know this is bone window and this is brain window. Okay. Scalp hematoma and skull fracture. Please look at the bone window on top. You can see there is break here. Hafiz, can you see the break? Can you see the movement of my hand? Yes. But on top of it, you can see there is soft tissue swelling around that side. Is that so? It's likely going to be a hematoma. Then come back to brain window. In brain window, we are going to see inside the brain. Can you see collection of white collection inside? Can you see white collection outside? This is what? Blood. But you cannot see fracture because this is brain window. But in bone window, you can see fracture. Meaning that you have to look at the bone window and the brain window to be able to know whether there is skull fracture and there is also what? A hemorrhage. Therefore, you can see them. Then let's go to the next. You can see they are very apparent now. You can see in the bone window, we have applied this. You can see there is blood. And in the brain window, you can see. If we go back to this place, look at it, look at it under. Remember, we said only bone appear white. But blood can also what? Acute blood can appear also what? White. But if the blood is up to 3 weeks, it will appear what? Hypodense. Okay, you can see it, meaning that at least we should be able to appear this. Then we now have depressed skull fracture. We have a skull fracture that is what? Depressed. I have a child, what do you call it? A child that came to me through my relatives. I took him to AKTH. He has a depressed skull fracture. But they did CT and everything. He did not develop any neurological deficit. They gave them 1 month to come, 2 months to come. Later, they said we should leave it like that. We shouldn't do anything. It's a depressed skull fracture. Look at the bone window. You can see it has shown you the fracture. Even the what do you call it? The brain window has shown you some fractures. Is that so? But what is most important in the brain window? You can see on top, there is a tissue that looks whitish. It's like blood. You can see under the fracture, there is a tissue that looks whitish under the brain window. Is that also? It's another blood. Remember, we said acute blood is whitish, but it's never as whitish as what? Bone. Then now look at this. Can we now make sense? You have now seen extradural hematoma. You can see extradural hematoma. What is this extradural hematoma? Okay, I will tell you. Extradural hematoma is the hematoma that occurs between, what do you call it? The bone and the dura mater. Extradural is between what? The calvarium and what? Dura mater is what we call the extradural hematoma. Okay, the next is mass effect versus what? Symmetry. Remember we said we have, what do you call it? Okay, remember we said we have ABBC scope. Now, we have done the first one, which is what? The scap. That is this, the what you call it? The scope. Then we are coming to symmetry. That is, mass effect versus what? Asymmetry. That is the A. Is that also? Mass effect versus asymmetry. What is this asymmetry? Remember we said asymmetry arises as a result of tissues, either edema, either what do you call it, cancer, or any collection in the brain, either what do you call it, inflammation, that actually tend to shift the structures from one side to the other one. That is what we call mass effect. That is what we call mass effect. They said intracranial pathological process will cause mass effect displacement or compression of the brain. The displacement, you may look high doubt, but this appears is normal. But when you look at the structures very, very well, are you with me, please?
Yes, sir.
Okay, when you look at the structures very well, most especially when you see hypodense area, it's like shifting towards one side, and you can never see this is the line of the false symmetry cerebri. It's like there is a kind of asymmetry. It is caused by intracranial space occupied lesions such as edema, intracranial masses, and hemorrhage. Okay, now let's take example here. Observe this. This one will appear normal, but it's actually not normal. Something is wrong somewhere. This is the CT of somebody who is elderly, but something is wrong in this picture. Observe the black area. Can you see they look very big? The sulcus, they look very big, and the gyros are shrinking. Is that also? This site is what we call normal for an elderly person. This is what? Normal. But look at this guy. Look at the whole of this place. You can never see any black. It is just a gyrus. You can never see gyrus. You can never see what? Sulcus. Is that also? There is no differentiation here. It's telling you that there is an effusion in this place. And you can see the white matter around this side. It appears whitish. Is that also? Meaning that there is an effusion in the whole of left what? In the whole of left hemisphere. That is the mass effect. Okay, now let's look at it. You can see this is normal sulci, but this is also not a young person. Altogether, it's an elderly person because he has lost what? Volume. But you can see this one, there is what? A mass effect. Mass effect meaning that it covers almost the whole hemisphere. That is a mass effect. Okay, now look at another mass effect. Observe. Now look at the two ventricles. The first one is big. The one on the what? On the left. And the one on the right looks very more small. And then look at this whitish. It's a collection of blood. You can see it. Then observe this. In between this and this, there is area that looks like water pour on it. It's gray. Is that also? This is an edema. But the most important thing we should know that around this place, there is what you call effacement. What do you mean by effacement? There is what you call it? Pressure is being put on the what? On the what do you call it? On the right ventricle. Why? The right ventricle cannot is not actually dilated the way it's supposed to dilate. Is that also? Meaning that there is a collection that is pressing on it. The other one is fully, you can see it. It's fully dilated in an in a grown person. But look at this guy, it's very small. It is being covered, it is being compressed by both edema and this, and you can see it very, very clearly. Okay, that is what we mean by what? If you cannot see symmetry, then something is wrong in the asymmetric side. Then we now have acute stroke. Here in acute stroke, remember we said we are looking for blood. Remember in the symmetry we have seen, in the trying to get symmetry we have seen blood. Is that also? Yes. When you are looking at the A, B, B, C, S, in the B, they say we should look for what? Blood. Even in the acute symmetry, you can easily see what? Blood. Therefore, when you enter stroke, you are likely going to see ischemia, the hypodense and hypertense, meaning that we are looking at the brain now. We want to see hypodensity areas, we want to see what? Hyperdensity areas, and we want to see, we are going to see ischemic and hemorrhagic what? Stroke. We said ischemic stroke now. The area of hypodensity in a vascular distribution is 70% due to what? There is area of hypodensity in a vascular distribution due to what? Cytotoxic edema. What do they mean? Meaning that in ischemic stroke, you are not likely going to see that white tissue as seen. You are likely going to see that area that looks like this. You can see the area that looks like, if you can see my cursor, the area that looks like water has poured on it small. Is that also? That is what you are going to see. Instead of white tissue, it's like edematous, and you know ischemia is associated with edema. Therefore, you see area of hypodensity. That is what they mean. They said, one, they say mass effect or generalized compression of ventricles, basal systems, and midline shift. Meaning that in ischemic stroke, you are likely going to see what? Mass effects. You are likely going to see big area of ischemia pushing down on other what? Structures. Then they said hemorrhagic transformation may occur 2 to 4 days in up to 70%. But the most important thing is, let's look at the ischemic transformation. Let this one not confuse us. Go. Let this one not confuse us. Okay, now let's look at the ischemia, the acute stroke. Okay, now look at acute stroke. Unlike in edema side, where you see whitish, please, can you see my cursor? Can you see this side on the left side?
Yes, sir.
This is area of ischemic stroke. This is area of what? Ischemic stroke. Yes, this is area of ischemic stroke. Then where you are seeing, it's like there is tilt in the head. That is why it's as if you now see that, like the falx cerebri is what do you call it? Is bent. It's not bent. We should also note that at times the head of the patient may be tilted altogether. It's the tilting that causes it, but it's no mass effect. But remember, it's almost a mass effect. It's like it nearly covers the whole what do you call it? Hemisphere. Is that also? This is ischemic stroke. Look at another ischemic stroke. Can you observe this place? Can you see it? Can you see this side? The all other sides look gray, but this one looks what? Dark. These ones are areas of what? Acute ischemic stroke. Then, now, observe this again. Look at this guy with two lateral ventricles. Can you see where these arrows are? Look at this. You can see there is a watershed infarction between two middle and posterior cerebral artery territories. Can you see it? Yes. Observe this one. Look at this guy. Look at this side where my cursor is, where this arrow is. You can see there's another place where as if water has dropped in that place. Those ones are what? They are areas of infarction. What we mean by areas of infarction? Where there is what? Microscopic death of what? Tissue due to ischemia. That is the infarction. Observe, there is area of calcification here on top. What is this calcification? Is that of falx cerebri? Is that also? We told you in the bone side, at times you see areas of what? Calcification. This is no blood. This is on the what? Falx cerebri. You can see in the middle, you can see the falx is also calcificating. You can see. Therefore, that is why we have to know where are the areas of calcification, normal calcification, and where are the areas of what? Broad hemorrhage. Go. Then chronic ischemic disease. Remember, we have talking about what? acute ischemia that looks like water pour on something. Oh, the acute ischemia, you cannot differentiate it with what? Edema. Because ischemia is always associated with what? Edema. Okay? Then, another thing, please, we should understand is that even the radiologist requires some clinical information. At times, the radiologist will now ask, in the form, they will ask, what is the diagnosis? Is that also? The provisional diagnosis. The doctor will say, we are querying stroke, because it will now give them insight into what is likely going to be. Altogether, yes, it's very, very important. When the initial assessment will also help physiotherapists to now focus on a particular area. It's not like just be looking at everything. What is the initial diagnosis? What is the presentation? You are querying so, then your mind will go to that place. Not just that reading X-ray, what do you call it, CT. The whole city, it may take time for somebody who is a radiologist. There has so many things to present. That little diagnosis or query used to give them insight. Then the next is chronic ischemic stroke. They said chronic ischemic stroke, what do you call it? This will change, present with a loss of parenchymal mass associated with what? Sulcal and ventricular widening due to encephalomalacia. What do they mean here? Okay, what they mean here is when somebody is having chronic ischemic stroke, when you compare his, what do you call it, X-ray, with the X-ray he took when it is acute. Remember, the acute ischemic stroke has to do with, what do you call it, the infarction area and edema together. Is that also? But in chronic ischemic stroke, it will look darker. That's one. And you look at the sulci and the gyrosis. The sulci and gyrosis are likely the sulci and gyrosis are likely the sulci is going to be big and gyrosis is going to be what? Small. In the sense that, meaning that when somebody is having a chronic ischemic stroke, due to physical inactivity and the rest, is likely going to lose brain volume. It's another correlate that, okay, when you compare the old and new, there is likely going to be brain volume loss in addition to what? In addition to the ischemia side. Therefore, we have small vessel disease. It can be presented, what do you call it? The changes can be in form of blood vessel disease, old ocular infarct, and territorial infarct. Let's take this as an example. Like, let's look at this one. Small vessel disease. Look at the white matter area. Look at predominant white matter area and some areas of the gray matter. You can see it's hypodense. It's as if you pour some black things. These are some sign of what? Chronic ischemia. And then another thing you should look at the gyri. You see them, they look big. Is that also? The gyri looks, the sulcus look big, and the gyri looks shrunken. Is that also? This is a sign of what? Chronic ischemia. Then, now look at Okay, thank you for listening. We lost what do you call it, connection, but we are back now. Hello, are you with me? Hello.
Yes, we are with you.
Okay, we are talking
Yes,
about
sir.
yes, we are talking about chronic. The chronic is a bit different from the acute. In the chronic, what happened is the area of infection is still there. It's look a bit darker, but what is happening is we should look at. Remember, we talk about loss of brain volume. Then the chronic is also is always associated with loss of brain volume. You now see the area of infection is still there, but when you look at the gyrus and sulci, the sulci will look big and the gyrus will look small, meaning that the guy has lost brain volume. Then it's chronic. Then we give example. We have it here. This is what you call the small vessel disease. This is chronic. And remember, when you see the other side, all the other sides, the gyrus are very prominent and black, and the sulci and the gyrus are becoming small. Then when you look at this guy, the same guy, and sometime later, the one here where my cursor is, this is the acute, where you have almost a mass effect here. Then you can see the gyri are small and the sulci are small. But here, after some 3 years back, forward, probably doing rehabilitation or something, look at the gyri have what do you call it, have become smaller and the sulci have become what? Big, with more of CSF. Therefore, he has lost volume. This is a chronic, this is what? Acute. Then we now have hemorrhagic stroke. Then this is the one that is very easy to see. The hemorrhagic stroke appear white like our bone, only that it's not as white as bone and it is not sharp. It usually is irregular. Then we see the surrounding edema will result to loss of gray and white matter. They said acute hemorrhagic stroke is hyperdense, meaning that it appears whitish. Okay, it can also be associated with mass effect. What do you call it? Compressing, sulci, ventricular compression, midline shift, and everything. It's just like ischemic stroke. They say the size and of the hemorrhage is important. It will influence future treatment. Then now let's look at the radiographs. Okay, you can see this looks like what do you call it? A collection of white something here. What is happening is, observe very well. Look at the what do you call it? The falx cerebri. It is never straight. It is roundish. That is to tell you there is mass effect. There is pressure. What do you call it? Pressing on the what do you call it? On the falx cerebri, there is what you call mass effect. There is shift in this asymmetry. Another thing is that apart from this whitish blood collection, look at the other side. You can see what do you call it? Some areas of gray, dark gray, that looks like water poured in that place. That is the edema that is usually associated with what do you call it? Hemorrhage. And then observe here on the right side. Observe there is sulcus. Look at the sulci here. And on this place there is what? No sulcus. The sulcus are very, very small, meaning that there is widespread edema in this place compared to this place. This place looks normal. This place looks effaced. Effaced meaning that there is effusion, meaning that there is edema in this place. This is more pronounced here. Look at the other side. The gyri and the sulcus remain unpronounced like the other side. That is acute left parieto-occipital parenchymal hemorrhage. Okay, now let's look at this guy. Look at this place. Observe some things happen here. If you can see my cursor, this is where the hemorrhage is. Look at the two lateral ventricles that are supposed to be black. They're supposed to contain CSF. Look at them, they look white. That shows that something is wrong. Look at the third ventricle. That blood has already passed through that side. Then look at this side. Look at the brain parenchyma around this side. That is what you call, what do you call it? Subarachnoid. What do you call it? Not subarachnoid. What do you call it? What do you call it? Yes, subarachnoid hemorrhage. Yes, this subarachnoid what? Hemorrhage. Therefore, you can see some hemorrhages here in the subarachnoid area. You can see hemorrhage here. You can see also blood going into the two lateral ventricles and the third ventricle. This is an acute blood. It appears whitish and gray, but not as whitish as the bone. Then let's go. Then look at another one here. Look at the two lateral ventricles. But at the tail end of the what do you call it? The left lateral ventricle, there is blood collection. Is that also? That is why we say we have to understand. We have to understand calcified areas. You can see this is not a calcified area. It's a blood. But look at it, the mouth of the dog. You can see the calcified area when it's normal. Cool? Then look at this side. There is hemorrhage. Cool? Then observe the other side here. They look very well. The contours look very, very well. Very okay. You can see it. You can see the contours here as I'm going around. But can you see the contour around that side? Meaning that there is little effusion. There is loss of what? The sulci and gyrus is here, meaning that there is edema around this place. Meaning that at least we should be able to say this is, what do you call it? This is hemorrhagic stroke. This is acute hemorrhagic stroke. Okay, hope we are going. Okay, look at it, acute hemorrhagic stroke, centered on the left thalamus. Centered on the left thalamus. Okay, remember again. Remember the thalamus area. We have the two lips of the dog. Is that also? Look at the mouth of the dog around this place. Look at the two lips, 1 and 2. You can see the meaning that one of the thalamus is what? Having hemorrhage. And then remember the other areas here. We can have lentiform nucleus. We can have what do you call it? The basal ganglia and the rest. Okay. Now, we are going to meninges revised. We are going to look at subarachnoid, subdural, and extradural hemorrhages. These guys are more easily to spot than any other one, unless okay. Let me release the video. Okay, can you see me?
Yes.
Can you see my hand?
Yes.
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 Yes. If you see a hemorrhage that looks my hand like this, is a different hemorrhage entirely from another hemorrhage that looks like this by convex, is it by concave? Go. If a hemorrhage looks like this, it's different from a hemorrhage that looks like this. Therefore, you are going to see them. One hemorrhage will look like this, the other one will look like this, and they are always like that. Then you should be able to know which one is which one. Then we now differentiate between what are these meninges. Remember, if you want to remember the meninges, they are DAP. DAP, dura mater, arachnoid, and pia mater. Dura mater is the one that is attached to the skull. Only pathology can separate them. Pia mater is also strongly attached to the dura mater. And arachnoid is attached strongly to the dura mater. Only pathology can separate them. But one thing with the pia mater, look at the pia mater, the one in yellow. You can see it. It's not attached to all of them, because there is what you call what? Subarachnoid space between what? The arachnoid and the pia mater. But the dura mater and then the, what do you call it? The arachnoids are attached. Only pathological process can tear them apart. But the pia mater is far away because there is also space between them. Okay, now let's take each one of them. Subdural hematoma. It arises between the inner layer of the dura and the arachnoid membrane. Remember, the dura. Okay, let me explain to you, please, before we do this. Do you know what we mean by extradural? Extradural, look at it this way. The bone comes first, is that not so? Then the dura is attached to the bone. Then arachnoid is attached to the dura. Then the pia mater is loosely far away from what? The arachnoid. Then if hemorrhage occur between the bone and the dura, that is the first layer, is that not so? That's what you call extradural. Extradural. Between the bone and the, what do you call it? Between the bone and the dura mater. Between the dura mater and pia is what you call what? Subdural. Then the bleeding into what do you call it? Subarachnoid space, already we have known it. Is that not so? Okay, so now let's go. We said subdural hematoma arises between the what do you call it? the inner layer of the dura and the arachnoid space. The high-density crescentic fluid collection between the skull and cerebral hemisphere. What is crescentic? Just like C. You know crescent? Crescent is like a new moon. Yes, for those of us Muslims that used to sight moon, you see it crescent shape. Some countries have crescents in their flags. Then also it looks like C. When you see it, then it is subdural hematoma. It is concave inner margin, convex outer margin, following normal contour. But just the most important is what? Concave inner what? Margin. Looks like C. It follows the contour of the cranial vault. Then this is subdural hematoma. Then you may also see signs of mass effect, compression of overlying sulci ventricle and midline shifts, meaning that this midline shift and mass effect is very, very important for us to look. Then observe. Look at two types of subdural hematoma. The first one, shallow acute subdural hematoma. You can see it follows the contour of the what do you call it? The skull. And the inner side is C-shaped. Look at this one, large right subdural hematoma. Observe, the inner side is what? C-shaped. If it is not C-shaped, and it is what? By concave. Is it by concave or so? Like two C's put together. Then it is not subdural hematoma. It is usually what? C-shaped. This is large and this the other one small. Then we have subacute. Okay. Okay, we have subacute subdural hematoma. They said after 1 to 2 weeks, the subdural collection become isodense to gray matter. What do we mean by isodense to gray matter? The blood will not be as clear, will not be very, what do you call it? Whitish the way it is now. It will look a bit almost the same thing with the gray matter, but only takes good observation, you know, that it's a subdural hematoma, but it is after 1 or 2 weeks. It can be recognized. They said only be recognized due to persistent mass what? Effects. Meaning that this is not easy to recognize, please. They said detection may be what? Challenging. Detection may be challenging. Only recognized due to what? Persistent mass effects. What is the mass effect? We have said it several times. Effacement of cortical, deviation of lateral ventricle, midline shift, while matter buckling, displacement of gray matter. We have said it several times. Go. They said contrast enhancement always define cortical subdural interface, meaning that where you are unable to see clearly, this is subdural because it is chronic and it's like becoming isodense, meaning that it's becoming almost the same color with the normal tissue. Then you have to apply what? Contrast. Then the area will now become very apparent. Now, observe this picture. Observe this picture. Observe this picture. Look at very close to the calvarium. The place look a bit whitish, but it's almost isodense. It's very, very close. And then remember, Hafiz, can you see my hand drawing downward? Look at it. Look at my hands. Look at it as it goes down. It's a very large subdural hematoma. All together. Then where you have here is a chronic what? Subdural hematoma, but it has become isodense with the tissues. They said if it is not clear, you have to apply what? Contrast. Acute is easy to see, but chronic may not be very easy to what? See. Then even if it is radiologist that was unable to see it, then remember we said part of what will help even the radiologist is what? The hospital value. Is that also? The hospital value of blood will now differentiate with normal tissue. Then you know, okay, this is blood. Okay? This is very, very important. The only thing is that whether it appears on the hospital value, whether it's appeared on the CT, or it is on a particular software they use in the reading the X-ray, that is what we don't know. Oh, probably it appears on the CT. Okay? Then we now have chronic subdural hematoma, taken after 2 weeks. Okay, it is often hypodense. What do you mean by hypodense? It is like going to become like ischemia. It's going to become hypodense. Collection are crescentic in shape and of course without mass effect. Look at it. Now it's very clear. The other guy is not clear, but this is now chronic. Is that also? You can see it has already shown that it's hypodense. Okay, then it follows the contours. Then we now move to extradural hematoma. Remember we said extradural hematoma occurs in between the calvarium and what? The dura mater. They are always together, stick together. Only pathologic process can remove it. Then hemorrhage arises in the potential space between what? Skull and the dura. The dura is attached to the skull, and the dura is the toughest after the skull. Is that also? Then when you see collection in between them, then something is happening. Then they say biconcave hyperdense elliptical collection, sharply defined edge. What do you mean by concave? By convex? Somehow, like your two hands together, like this. Yes, putting your two hands together, like this, the two C's together. Hematoma does not cross suture lines unless fracture is what? Present, meaning that it's always collected in one area. And then, do you know why it is always collected in one area? The dura is very, I told you, tough and strong. Therefore, it does not pass through the suture except there is what? A fracture. I think that is what they mean. Then they said, may separate the venous sinuses and falx from the skull. The only type of cranial hemorrhage that do this. What do they mean? In all the hemorrhages, we have never seen where the falx, blood will pass through the falx cerebri. Is that also? They said this is the only type, extradural hemorrhage, that will now pass through what? The falx cerebri. That is what they mean. They said the only type of what? Intracranial hemorrhage that what? Does this. Meaning that if you see blood inside falx cerebri, then it is what? Extradural hematoma. Mass effect depends on the size of the hemorrhage. Meaning that whether the whole hemisphere is inflamed, it depends on what? Size of the hemorrhage. Then we now have, this is what we call extradural. Observe it. Look at the color. It's a bit whitish again. Is that also? But the problem is it looks roundish. It looks like the two C's are put together. The other one is what? It's crescent shape. It follows the contour. Is that also? But this one is what? Roundish. It is telling you that it's the dura mater that actually was forced to go down, but it refused to go. Is that also? Then it is roundish. It is like two C's put together. That is what you call it. And then again, observe this. There is mass effect in this one. Please observe the mass effect. Look at my hand. If I am drawing line, you can see the falx is not straight. You can see the falx is not straight. Look at the two ventricles. You can see one of the lateral ventricles, one of the two big ventricles, you can see is what? Is prominent. Especially the one on the left. Can you see the one on the right? The one on the right is missing. Is that also? You can only see the whitish of the correct plexus. Is that also? Therefore, meaning that there is likely mass effect on this side. Are we really understanding? Okay. Then look at another one. Look at another one. You can see, look at another subdural hematoma. You can see it also looks what? Biconvex or whatever. Look at the two C's are like put together. Cool? That is the way it looks like. Okay. Then the last one is subarachnoid hemorrhage. Is what? Subarachnoid hemorrhage. Remember, we talk about subarachnoid. We said arachnoid is not, what do you call it? It's not attached to what? The pia mater. Is that also? Remember, dura mater is attached to the skull. Pia mater, arachnoid is attached strongly to the dura mater. But we said pia mater is not attached strongly to, is not even very close to what? The arachnoid. There is subarachnoid space. Is that also? Therefore, subarachnoid hemorrhage involves bleeding into what? Subarachnoid space. I think we have said it. And then if to revise this one, we have said it that this is it. Look at the arachnoid. This is the subarachnoid space. If there is any bleeding into this place, this is what they call the what? Subarachnoid hemorrhage. The pia mater and dura mater are together, and the arachnoid and dura mater are together, but the pia mater is far away. Therefore, bleeding into subarachnoid space is what brings about what? Subarachnoid hemorrhage. Okay? Okay, now subarachnoid hemorrhage, bleeding into the subarachnoid space between the arachnoid and the pia. They are not attached to, Therefore, they could cause raised intracranial pressure by obstructing ventricular flow of CSF. They said blood localized to basal cister sylvian interhemispheric fissures suggests rupture of what? Circular aneurysm. What do you mean by circular aneurysm? Meaning that a blood vessel that is already dilated due to hypertension or anything, it will break. Clot lying over cerebellar convexities or within the superficial brain parenchyma suggests rupture of what? What do you call it? AVM malformation, meaning that what is this AVM? It's malformation. It's what do you call it? Arteriovascular malformation. Then they said, therefore, what we mean here is that usually subarachnoid hemorrhage may occur as a result of trauma, and it may not occur as a result of what? Trauma. It may occur as a result of what? Rupture of an aneurysm into the subarachnoid space, or as a result of trauma into subarachnoid space. Okay, then we now have subarachnoid hemorrhage. Now, when you are looking for subarachnoid hemorrhage, somebody may be looking at somewhere very close to the calvarium, close to the skull, whether he's going to see C-shape or he's going to see, what do you call it, biconvex. But this one is not like that. Usually on the right, what you see, look at the whitish on the right here. In subarachnoid hemorrhage, there is bleeding into the brain tissue. The other one, the bleeding is not into the brain tissue. The bleeding is contained very close to the scalp. Is that also? In the dura mater, it is usually like double C put together. Then in the that's in extradural. In the subdural, usually it's C-shaped, but it's still contained. But this one, there is bleeding into what? The gray matter. And look at it here. The whitish looks like bleeding into gray matter. Somebody will say, okay, what differentiates this? Observe. Look at my cursor. Look at the gyri are very, very prominent here. Look at the sulci are a bit prominent here. Look at this guy. But on this side, there is no sulci or gyri here. You can see it, huh? None. And then you can see the whitish here. Then they're likely going to be subarachnoid hemorrhage. Then observe. You can see subarachnoid hemorrhage. You can see this one also. Look at the sulci here and the rest. Look at this here, but it's missing here. Look at this. It's as if somebody has washed clothes and the clothes, he did not rinse the clothes very well. If you wash clothes, like for example, black clothes, and then you wash them with soap, and you did not rinse it very well, it appears some whitish. That is what appears here. This is what they, what do you call it? Bleeding into subarachnoid space. Hyperdense subarachnoid blood clotting, several sulci within the left hemisphere. This is the left hemisphere. Cool? Then finally, we said, okay, I did not write the conclusion. Accurate reading of what do you call it? Accurate reading of the what do you call it? Of the pathologic CT requires following the systematic approach of what? ABB, then what? C, then we have S. ABB, CS. Thank you very much for listening. I hope by the end of this presentation, we should also have, what do you call it? We should be physiotherapy. We should also have eagle eyes. We should be able to attempt reading, what do you call it? A CT scan. Thank you very much for listening.
Thank you, sir.
Okay, comments, contributions, questions? Sorry, we're supposed to have finished by 3-4 o'clock, but because we have serious problem with the network here, the network keep fluctuating. We are unable to finish, but I hope with this, at least when next we are talking, what do you call it? CT scan of a child brain, we shouldn't come back to this one. We talk as if we know it. We'll just be discussing. We have a background. This is like can I say, a foundation lecture. Next, we are going to have a lecture covering different conditions that we should be able to use, what do you call it, in our day-to-day clinical assessment and reasoning. Thank you very much for listening. We hope to see you next week, by God's grace.
Thank you, sir. I have a comment, sir.
I really appreciate you for waiting.
Hello, sir.
Okay.
I have a comment, sir.
Okay, yes. Say the question loud so that I can hear you.
Okay, sir. I have a comment, sir.
You said?
It's not a question, it's a comment. It's a comment,
okay.
Sir.
Okay.
Yes, sir. Sir, I must commend you for your rare ability to enthusiastically and detailed information. And the way that you teach it in a way that is neither overwhelming or boring, I think it's really thank you so much for sharing your tips with us, sir.
Thank you, Ma. And it's actually part of what we have to do. As when as I teach, I also get to understand it better. And one day we hope to have one of you as one of our resource persons, so that you build up upon what we have discussed now. We really appreciate you for coming, and we shall see you next time, by God's grace.
Apa?